we'll give everybody just a couple more minutes to come in because I'm not sure where everybody is. Not sure where everybody is this morning. It's Monday. Good morning. The shop at 10. You don't need your blood pressure cuff right now.
Yeah,
You'll need it after break. Good morning. All right. So are you guys getting our emails, our wrap-up emails? Is everybody getting our wrap-up emails? Have you checked? If you are not getting our wrap-up emails, please let me know after class, and I can check your email in the system to make sure that we didn't put it in wrong, that there's no typos. You may also want to check your spam folders as well, because we're a high volume site. We send out a lot of emails. So sometimes email providers classify us as spam, which we're not. All right. Those of you joining from YouTube world, you can also get those wrap-up emails. Just go to foryourcna.com, YouTube live class, and there should be a form there for you. All right, so over the weekend, you had 2 chapters to read, chapters 2 and 3 in the yellow book. Did everybody do your reading? They were long chapters and a little boring. I know. Once you did your reading and took your test, did you grade it using the answer key on page 201? Okay, I am going to get your test scores now. Hold on one second. What is this? Why do I have this? Oh, no, that's no good. Okay. Okay. So we are on 12. There we go. All right, so let me get your scores. When I call your name, let me know either how many you missed for chapter 2 and then chapter 3, or your scores if you did the conversion. If you don't have it, just say pass, and I'll get it from you next time. Victoria? Janelle?
Chapter 2, I got one wrong, and then I didn't know which was chapter 2.
Okay, do you have chapter 1 for me as well? Page 181.
No, I don't have the other.
No worries. Elizabeth? Zachary? Kiera?
Pass.
Do you have chapter 1 for me by any shape? Pass. Okay. Paula? Okay. Neftali?
75.
On chapter 2?
Yes.
Okay. Did you do chapter 1 as
Yes.
well? What'd you get on 1?
Pass.
How many did you miss? None?
Pass.
Okay. And did you do chapter 3? How many did you miss?
3.
3. All right. Do you have any questions on the ones that you missed?
Yes, that's it.
Okay. We'll get to that later. Isabel?
Chapter 2, I missed 2.
Okay.
And chapter 3, I missed 1.
Thank you. Andrea? Cassidy? Giselle? Lacey?
I missed 1 on chapter 2, none on chapter 3.
Very good. And Queenie?
75 and 85.
Thank you. All right. Those of you who missed questions, does anybody have a question on what you missed? Like why the right answer is the right answer or why yours wasn't a right answer? So for either chapter 2 or 3.
I don't have questions of this because I answered it first and then I read it. But then, why I'm wrong? So I read it again and I find the answer.
Okay.
I have a question on page 49 about nursing assistants should not wear rings and bracelets, and because in my workplace I noticed CNA there, they have long nails longer than mine and they rings and jewelry. I was like, but I'm asking maybe if we go to the test, maybe we don't wear rings.
It's not a part of the test. They don't care. It's not a graded checkpoint. But let me explain to you something about rings and bracelets. Although I understand, the need to look nice and, to feel good about yourself, right? So a million years ago, when I was a brand new baby nurse, thought I knew it all, right? I was working and I was changing either the chucks or changing the sheets or doing something under a particularly heavy patient. And she was morbidly obese, probably north of 400 pounds. She was a larger individual. And I had her on her side and I'm tucking things underneath her. Well, of course, I've got gloves on. And as I'm tucking, she actually rolled back onto my hands. So my hands are stuck under her. And she was a heavier individual. So as I tried to pull my hands free, because I was working alone, as I'm trying to pull my hands free, my engagement ring broke through the glove and gouged her skin. So she had a deep gouge in her skin from my ring. Now, it took a very long time to heal that. And I felt absolutely horrible that I had injured this person. I mean, it really affected me. But even worse than that, now her skin and tissue is in my ring. And no amount of washing it in the sink is going to get rid of all of that. So I now have this woman embedded in a piece of jewelry that I'm going to wear everywhere. And that's not good. It's not good for infection control. It's not good if I'm wearing that ring in my kitchen while I'm cooking for my family. It's just not good. So, yeah, that's why rings and bracelets really shouldn't be worn in a clinical setting because of the risk of injury, but even more importantly, the pathogen problem. Does that make sense? Now, each place that you go to work is going to approach this differently. Some places will have a policy and procedure that says no rings or bracelets. Now, as a condition of employment, you're agreeing to follow their policies and procedures. Make sense? So you'd want to know what that is. That's a really good, if you're really attached to your jewelry, that's a really good question for an interview. What is your policy on jewelry in the workplace? Same thing with necklaces. A lot of people, have necklaces that they wear every single day. But those necklaces, if you're working with a confused combative patient, can be grabbed and twisted to injure you.
I've got my hoop pulled.
Sure, absolutely. Hoop earrings are another one. So most places have a policy and procedure on jewelry, and it's there to keep both you and your patient safe. A lot of people take this personally, and no one's going to tell me I can't wear my jewelry. And, that's completely between you and the employer. But I'm going to tell you, it's probably not the best policy to wear items in a clinical setting that you're also going to be wearing in your kitchen when you're cooking. I mean, that's just kind of that's my standard. As you notice in here, I don't wear rings. I don't wear necklaces. I don't wear earrings. Hi, good morning. And I'm on camera. Okay. So I'm broadcasting myself out to the world with no makeup on, right? I am a brave individual and no jewelry, nothing to sparkle more than I do, right? I have to rely on myself to sparkle. But the reason for that is because I want to teach you the best way to care for your patients. That doesn't mean I don't have jewelry. I do. I just don't wear it at work. I save it for when it's appropriate. Does that help you? It's not a testing checkpoint. Nobody's going to say anything about your jewelry in the test. But if you're wearing bracelets, they are going to watch whether you're washing the bracelets as well as your hands. So you're adding a level of complexity to the infection control standard on the test. You probably don't want to make the test any harder than it already is, though, I don't think. So I would leave those off. Now, as far as nails, again, nails are going to be dictated by your facility policy. And it used to be years ago that they didn't allow any acrylic nails or gel nails or anything. Nothing, nothing but natural nails with, you could have like a natural coat of polish on them, but nothing basically that could injure the patient, right? So the reason is that especially acrylics harbor bacteria. They actually get up underneath the acrylic, between the acrylic and your natural nail. And that's warm, dark, and moist. So we end up, because we're washing our hands a bazillion times a day, we end up creating this environment that can breed pathogens very easily. And again, this is something you're going to have in your kitchen, right? When you're cooking, you're taking your hands to your kitchen. So you don't want to have an environment where pathogens can proliferate under those nails. So most settings had that as a policy procedure, no acrylic nails. They kind of loosened up on that a little bit. And, a lot of places are now, we don't care as long as they're short enough that they're not going to injure the patient. They don't have that really sharp tip on them. That's like the style. Well, about a year ago, that was a style to have like that really sharp tip on the end. Everything's at a point. I would definitely avoid that. Me personally, I would not wear acrylics just because I understand the pathogen problem there. And I don't want anything in my kitchen. I cook. Can you tell? I don't want anything in my kitchen that could contribute to, my family's ill health. Does that make sense? So you're going to want to follow your policy and procedure. Now, I quit doing it a couple months ago, but I used to do a weekly live lesson. It was the Q&A, the weekly Q&A. It was on Thursdays at 3. And I always gave a presentation. So basically a lesson that you don't get in this class. So it's all additional learning. And one of the things that I talked about one day was nails and why it's not a good idea to have artificial nails in the clinical setting. So if you're on my YouTube channel, go to my live tab and you can watch the replays of all of those lessons. And there's probably about 200 of them. That because I did it for a long time. I just got really busy and had to put it on hold for a little while. But you can find out things, lessons on lifts, automated lifts, what we call Hoyer lifts. You can find lessons on dehydration in the elderly, interview techniques, all kinds of stuff, right? So there's lots of lessons in there for you. All right. Any other questions on what you missed? Anybody else? Nobody's going to ask me about the 75 hours. So in your reading, it told you that CNAs, in order to be certified, have to have a minimum of 75 hours of training in order to be certified. If you add up the hours you're here, it's not 75. And that's because Florida is unique. Florida does not follow federal rules. I don't know why. I'm not real sure why we got a pass on this and nobody else did. I haven't figured that out yet. But we don't require 75 hours. You are allowed to challenge the test. And that's what we're going to get you ready for, is challenging the test. But that's important for you to know because it's not at least 75 hours of training. This certification or this class may not meet the needs of other states. It will for Florida. You're fine. You can test in Florida, but it won't meet the education needs for other states. So if you want to move to Arizona and they ask you, hey, can you give us the transcripts from the school that you went to? You're not going to have that because you're not in a 120-hour state-approved CNA program. Okay. So most states, though, they don't really ask. They say, oh, you've got a CNA certification in Florida? Cool. We'll give you one here, too. Give us some money. We'll give you a certification and you can work here. But you do need to understand that it does not meet the class does not meet the federal guidelines. And that can affect your ability to transfer out of state. Won't affect your ability to get certified in Florida, though. And Florida has all the work you'll ever need. We have a shortage. All right. Any other questions?
I have the chapter 1 score.
Okay. What's your name again?
Kiera.
Okay. Chapter 1.
I got 100.
Thank you. All right. Any other questions before we move on?
So when we have to take, like, if we moved out of state, we have to take a whole.
Every state is different in the way they handle this. So unfortunately, I can't give you all 50. But in your book, in the white book on page, hold on, let me tell you what page that is. 172 and 173. These are the CNA registries for every state. Like I said, I can't give you all of them because I'm just not that good. I don't remember all 50. But you can contact them and say, I'm a Florida CNA. I want to be a New York CNA. What is the process? And they'll let you know. Most states, the majority of states, as long as you have a certification in Florida, they're going to give you one in their state. You have to go through their background check because they don't cross. You have to go through their background check and pay a fee. Of course, nothing is free. And then they'll just give you one in their state as well. It doesn't take Florida's away. You don't give one up for the other. You can be certified in multiple states, but you're responsible for keeping up with the renewal requirements for each one of those. Okay. Other states are like, hold up, not so fast. We need some proof. And then other states are like, we don't care about proof, but we require that you take our test. And then other states are like, we don't care about any of that. You got to start over. So there's several different options that a state can implement for transferring certifications. You would want to contact, and they all change all the time. So you'd want to contact the state that you want to go to. I can tell you, New York, that's an easy one. Just let them know, pay a fee, do their background check, they give you one. Tennessee, they're one of the hardest. They make you go through their training and testing. So you're starting over. Okay. Good. Questions? Not too bad, right? All right. So let's review what we learned last week because we had a whole weekend in there. And I've got to make sure that you remember what we've learned. So how do we know what to do with each patient? We're going to follow the care plan. Not just the care plan. It's the care plan, the whole care plan, and nothing but the care plan. While we're doing that, while we're following the care plan, we're also going to be observing. And we're observing for abnormalities, changes, pain, anything that looks or sounds or smells or feels weird. And then who do we tell that to? The nurse. Very good. All right. So every skill starts with the opening. Every opening starts with a knock. That's our first step of the opening. Please remember this because when you go to test and everything flees your head, you're going to know exactly where you need to start. Every skill starts with, okay. Now, once we've knocked, we don't have to wait for a come in for the test. You're just going to knock and enter. But once you enter the room, what do we want to say to our patient? Yeah, we want to greet them. Hello, good morning. Yeah, something, right? You're not just going to go in, close the curtain, and start working on the patient. They don't know who you are. You're a stranger. Stranger danger. So remember, it's always about the patient. So we're going to greet the patient. And then we're going to identify them by name. So you can do these two steps together. Hi, Mrs. Jones. Good morning, Mr. Jones. You can do those two things together, but both of them are graded. So make sure you get both of them. Now that we greeted our patient, what do they need to know about us? Our name and title. Very good. And then we're going to tell them, yeah, skill. Insert name of skill here. What are you doing with them? Hi, I'm here to do vital signs. I'm here to help you with a snack. I'm here to make your bed. I'm here to do range of motion. I'm here to take your vital signs. What are you there for? Because they have to know this in order to give this. Permission. Yeah. They're not just going to give you a carte blanche and let you do anything you want to. Like, anybody ever been in an ER? Right? Yeah, they have to tell you what they're doing to you. They're not just going to take you in the back and crack open your chest and give you a heart transplant. Right? You have to know what they're doing. So not everybody gets heart transplants. Only the ones that actually need it. So we have to describe our skill and get permission. And then once we get permission, we can close the, right, but is that curtain clean? No. So what do you want to do after you close that privacy curtain? Wash your hands. You got to get rid of those cooties. Yeah. So once you've washed your hands and we now have clean hands, what can we go get for our skill? Get supplies. Our biggest step here, the most important thing that we need to remember about the opening is to not touch patient until our hands are clean. You cannot touch that patient until your hands are clean. That is the biggest thing I need you to remember about the opening. Now, once we've done the opening, then we're going to figure out if we need gloves for this skill. And gloves are not based on the skill. They're always based on the patient. So that's an important thing to remember. Gloves aren't based on the skill. They're based on the patient. Let me explain. If we're taking your pulse and your skin is intact and you have no scratches or scrapes or openings or body fluids or anything, and I'm washing my hands before and washing my hands after, I don't need to wear gloves to take a pulse on her. But you were just in an industrial accident and you've got scrapes and scratches all over your arms and hands. Even though I'm washing my hands before and washing my hands after, I could potentially touch open skin. So do I need gloves to take a pulse? So it's not based on the skill. It's always based on the patient. Good? All right. So how do we know when we're going to have to wear gloves? What are our 3 criteria if we're going to touch body fluids, non-intact skin, and personal skin? Anything normally covered by a bathing suit. Okay. Non-intact skin, personal skin. I'm sorry. Hold on one second, guys. I have a message here. I just want to make sure. Okay. Just want to make sure it wasn't Caitlin telling me I was not broadcasting. All right. So body fluids, personal skin, and non-intact skin. So if we're going to wear gloves, if we decide, yes, based on those 3 criteria, I need some gloves, when do we want to put them on? What's the first thing our gloves should touch? The patient. So should we have gloves on when we go get our supplies? Should we have gloves on when we do our opening? Should we have gloves on when we're prepping the patient for the skill before we actually do it? No. First thing our gloves should touch is the patient. All right. And then once we've touched the patient and our gloves are soiled, we have to be careful about what we're touching in the environment. Yep. Once we have gloves and we're done with them, we've done our skill, we need to remove the gloves. We have to make sure that we're removing them correctly. Remember, icky gloves don't need love. Don't let it touch your skin. Okay. So we're going to pinch up to remove the first one and go under to remove the second. All right. So now that we've done our opening, or I'm sorry, now that we've read our care plan to know what to do, done our opening, washed our hands, decided that we needed some gloves, then we have to figure out where we're going to put our gloves and the rest of our supplies. So we need a clean place to put our, what kind of supplies? Clean supplies. And that's what the barrier is all about. Remember that we can only touch supplies with what kind of hands? Clean. So the barrier is all about clean. Are you noticing how many cleans there are? But when we're getting those supplies, what can't they touch? Your uniform, because it is not clean. Again, there's that clean. Barrier is all about clean. And if we decide that we are going to use a barrier, when do we want to get it? At the same time we get our supplies or first? So we're going to go get that barrier first and put it on the table. And that's to keep our supplies from touching our uniform. Okay. So barrier first and then supplies. That way you have 2 hands to spread it out. All right. We also learned about the privacy blanket on Wednesday. You guys remember that? We learned about the privacy blanket. Privacy blankets are used anytime. I'm sorry, privacy blankets are used to keep the patient. What is our word there? Keep the patient warm. Yeah. What's temperature in here? Cold. Take your sheet away. Super cold. So we have to use a privacy blanket to keep that patient warm, but also to provide an extra layer of protection or privacy. Remember that the curtain shields them from everybody out there, but it doesn't do anything for the stranger in the room, you. So we know that we're going to use a privacy blanket if we're working with a patient that is uncovered or undressed. So if the skill requires that we uncover the patient, yes, you need a blanket. If the skill requires the patient is undressed in any way, yes, you need a blanket. If they're uncovered or undressed. Do we want to just take the sheet completely off the patient and then put the blanket on? No, because that exposes the patient. So the way that we do this is we put the blanket on top and then we pull the sheet down underneath. When we're putting that blanket on the patient, what do we have to be careful not to do? Yeah, snap it or shake it. And then it at the end of the skill, when we're going to remove the blanket, do we do it before or after we remove our gloves? What do you guys think? Those gloves that touch the patient, they have all kinds of cooties on them. You want to do it you want to remove the blanket after you've removed your gloves. And the reason is you've got to pull that sheet up. Remember, that patient can't be uncovered. So you got to pull that sheet up. Do you want to touch that sheet that's going to go right up next to their face with pathogen covered gloves? So we're going to remove our gloves first and then the blanket. Good? Make sense? All right. We also learned a little bit about linen rules, but most of these are repeats from another principle. So what can't touch your uniform? Yeah, supplies. Absolutely. What kind of hands do we need to get our supplies? Clean hands. We don't want to snap or shake our linens. Right. And then we also, we skip 2 because we're going to come back to those in a few minutes. And we also learned the last one. If we don't use it, what are we going to do with it? Do we leave it in the room for later? No, we're going to discard it, put it in dirty linen. Okay, and we're going to cover the rest of those later today. So great job. So every skill is going to end with the closing, and there's lots and lots and lots and lots of steps of the closing. Our main rule of thumb here is always leave your patient looking better than you found them. So what kind of environment do we need to leave them in? Clean environment. So clean and safe is important here. And safe includes lowering the bed to its lowest position. Why? Why do we have to worry about this? Yeah, we don't want them to fall. When they get out of bed, they expect the floor to be right where they left it. If we've moved that floor, they will fall because they've never had that experience in their life. Floor's always right where they left it. Okay. We want to use a specific word. What word are we going to use when we're talking to them? Comfort. Yeah. Are you comfortable? Now, remember, comfortable can be physical, like do you want the head of the bed up or down? Do you need another blanket? You know, comfort can be physical, but comfort can also be emotional. So we want to make sure that we're offering a magazine. Now, we've got millions of views on YouTube. I get probably about 40 comments a day on YouTube. And one of the comments that came through this weekend, I had to chuckle. Somebody typed in, Miss Patty sure does like her magazines. So remember that comfort is emotional as well as physical. So we're going to ask, are you comfortable? And we're going to offer a magazine as well. All right. We need to make sure that the patient is covered in some way. Remember, the temperature in the room is cold. You're not going to feel that though. temperature to you is going to feel warm because you're up, you're dressed, and you're active. So remember that you don't perceive temperature the same way the patient does. So when we leave the patient, they must be covered. Yeah. Is that good? Either with clothes or a sheet. I don't care, but they've got to be covered in some way. All right. So once we've done all of those things, we can then remove privacy. Okay. But the order here doesn't really matter. You can open the privacy curtain at the beginning of the closing if you want to. It doesn't really matter. But you want to set this up in a way that you're going to remember to do it the same way every time. Okay? Does that make sense? So, for me, I do it comfort, curtain, call light, clean. That's how I remember it because it all kind of goes together. Comfort, curtain, call light, clean. So I'll ask the patient, are you comfortable? Is there anything else I can get for you? Would you like a magazine? I'm going to open your privacy curtain. I'm going to give you your call light. Your environment is clean. And then I can go clean my hands. So comfort, curtain, call light, clean. They do need to have that call light. And I personally don't just give them the call light. I tell them how to use it. Because patients in a clinical setting either are going to have a physical problem, or they're going to have a mental problem, or they're going to be medicated. All of those things mean that I could hand them a call light. They have no idea how to use it, even though they used it 3 hours ago. Because pain medications wipe your memory. So when I hand somebody a call light, I usually will tell them, if you need me, press the red button. If you need help, use the call light. Okay? So don't just give them the call light. Tell them how to use it. And then once we've done all of those things, we're going to go wash our hands. We got to remove those cooties. But now that we've washed our hands and we have clean hands, should we come back to the patient to do anything else? If we come back to the patient, to their environment, and touch anything, what did we just put all over our hands again? Yeah, cooties. Absolutely. So don't wash your hands until you're all done. And this is, if you go watch other videos on YouTube, you'll see that there are several people that do this. They go wash their hands, then they come over and give the patient their call light. Here you go, Miss Jones. Why is that a problem? Yeah, and because you're not going to go wash you've already washed your hands. You're not going to go back and do it again. So that means that you're taking those cooties over to, another patient. Is that a problem? Yeah, so we've got to have a little bit more awareness. It's not just wash your hands at the end of the skill. It's wash your hands at the end of the skill and don't return to the patient. But during the test, if you realize, because you're going to be like all on super speed during the test, you're just trying to get it over with, right? So all right, Miss Jones, you good? Everything good? You need a magazine? No? Okay, I'm going to go wash my hands. You get over there, you wash your hands, you turn around and you realize curtain's still closed, no call light, you got a Chucks on the table, all this stuff. Don't ignore it. You got to address it. So give the patient the call light, open the curtain, clean your environment. But now what do you have to do? Wash your hands again. Remember, every single one of those things has cooties. Patient cooties are fine. They're used to their own cooties. They're happy there. Patient cooties are fine. We can give them to the patient. But we don't want to give those patient cooties to somebody else. Okay? Including us. Make sure you have clean environment or clean hands when you leave the patient environment. Once we've washed our hands, though, if we have to document, this pen goes home with me at the end of the day. Do I want to touch it with dirty hands? So I've got to wash my hands before I document. But now I've touched the pen and the paper and the table where I'm documenting. So what do you think I need to do after I document at the end of the skill? Wash my hands again. Because our big takeaway, just like with our opening, our big takeaway was don't touch the patient until your hands are clean. Don't leave the room until your hands are clean. Okay. So good. Questions on that? All right. We learned how to take a pulse. If you remember, a pulse is a measurement of how many times the heart beats over a minute. Okay, that's what a pulse is. In order to take a pulse, there's a couple of rules we need to know. What has to be supported? The arm, yeah, the elbow. Absolutely. Don't leave that arm hanging out in midair. You're not going to get an accurate reading. We're always going to report a pulse over what period of time? 1 minute. It doesn't mean we always have to count over 1 minute, but it does mean we have to report it over 1 minute. So if we take shortcuts, like we only count for 15 seconds, we would have to multiply that by 4 to get our minute reading. If you go up to a nurse and you say, yeah, the pulse rate is 20, the nurse is going to look at you like, yeah, that's like close to dead, right? Normal 60 to 100. That's like close to dead. Don't come out here and tell me the pulse rate's 20 unless you're panicking, because that's not good. Pulse rates are reported over a minute. So if you counted to 20 in 15 seconds, you have to multiply that out to get our minute reading. Does that make sense? So counting for 15 seconds is not enough. You then have to multiply to get that minute reading. All right. How do we know which method we can use? If we can count for 15 seconds and multiply that by 4, or if we have to count for a whole minute, how do we know? Yeah, the care plan. We're going to follow that care plan. Absolutely. And for the test, it's going to tell us to count for 1 full minute. So if you count for 15 seconds and multiply that by 4, even if you get the right answer, you'll still fail because you did not follow the care plan. All right. What's our normal pulse rate range? What's normal? 60 to 100. Yeah, I just gave that one to you. What would you do if you got something under 60? What would you do if you got something over 100? Report it to the nurse. But I'm going to stop here real quick, time out, and tell you there are times that you still have to report normals. So let's say that we got 62. We took this lady's pulse and we got 62. That's normal. 60 to 100 is normal. 62 is fine. We're happy with that. But when we go to chart it, everything else in her chart is 104, 98, 110, 96, 102, 90, right? And we got 62. Even though 62 is normal, should we report it? Why? It's not her normal. So when we're talking about normals, we have to remember there's normal values, but there's also normal for the patient. So if you get a normal value, but it's not normal for the patient, you have to report it. Hey, I got 62 today, but normally she runs in the high 90s, low 100s. And the nurse is going to go figure out why. Okay. What fingers should we use to take a pulse? Okay, your index and middle finger, these 2 fingers. Do we ever use our thumb? No, just these 2 fingers. And what area of the finger should we use? The fingertips or the flat parts? Fingertips, correct. Correct. Where is the radial pulse located? At the wrist. Where on the wrist? On the thumb side or the pinky side? The thumb side. Way down here or at the bendy part? At the bendy part. Okay. For the test, how is the evaluator going to know when we start counting and stop counting? We're going to say it out loud. Start when you start and stop when you stop. That way they know you're counting for that 1 full minute, but they can also count at the same time to judge your accuracy, because you can be off by 4 beats in either direction and still be considered accurate. So since we counted something for this skill, what do we have to do after we count? We have to document it. Don't forget to document. Okay. In Florida, how many evaluators are we counting with? 2. That means we have to count twice. Okay, good. Questions on pulse? All right, let's talk about dressing. So the thing to remember about dressing a resident with a weak arm is USA first. Anybody remember what USA first means? Undress strong arm first. Yep, that's important, because that allows the old garment to just slide right off without moving, and it allows the new garment to slide right on without moving. So this is actually very important. When we have somebody with a weak arm, we tell the patient or the family, go get us stuff that fastens up the front. Button, snap, doesn't matter. Nothing that pulls over the head. Because when you have clothes that pull over the head, you have to extend your arm. If you've got a weak arm, you may not be able to do that. Okay. All right. So what do we want to ask the patient? Yeah. What do you want to wear today? Absolutely. They have the right to choose their own clothing. And when should we get that clothing? Before we undress them or after? Before. Why? Yeah, they don't want to be laying there naked. Well, we're out trying to find clothes. All right. When we lift an extremity, how do we lift? Do we lift from above? Okay, we're going to support at the joints, but do we lift from above or below? Below, and we support at the joints. Yep. We're going to undress strong arm first and dress weak arm first. We don't want to overextend or force movement. Did I show you her? I didn't show you her ankle. Let me show you her ankle. I missed this. Let me show you something. All right, give me just a second. I got to get my handy dandy Turner thing here. I'll show you why this is important. Okay. So let's go way over here. You see her? We were a testing center for many years, and she was one of the testing mannequins. Her name is Sally Mae. And remember, this was a testing mannequin. People actually used to test skills using her. We had to take her out of service. The reason we had to take her out of service is because of this. Is that a normal position for a foot? Okay, what you need to understand is what is holding this up. If you look at this foot, it doesn't do that. What is holding this is a steel cable. Steel cable. It would take a whole lot of force to break this. And somebody did. If somebody did this to a mannequin with a steel cable holding it together, what do you think would happen to a live human? Yeah, we would break them, probably in several pieces. Dressing. Putting socks on. Do we want this person working in healthcare? Do you want this person working on you? Let's cut to the chase here. Do you want this person working on you? No. This is why the test exists. Okay? It's not all these little minute details that they're looking for a reason to fail you. That is not what this is about. They want to prevent that from happening out there. That's what the test is all about. Okay? So your focus, because your mind is, oh my gosh, I'm gonna, I'm testing. It's all about me. It's not. It's all about the patient. Yeah, if you're breaking their ankle, you're probably not going to be a good CNA. Okay? So we don't want to overextend or force movement. And by the way, when that happened, the person testing said, I don't understand why you failed me. I wouldn't have done that to a real person. It's just a mannequin. That is not just a mannequin. That is Mrs. Jones. It's not just a mannequin. Does that make sense? That your evaluators give these things personalities. They are real. So we have to keep that in mind when we're performing the skills. We're going to treat them like they're real. We're going to talk to the mannequins. We're going to tell them what we're doing, because in that evaluator's mind, those things are real. They're patients. Absolutely. So don't overextend or force movements. After we've gotten them dressed, we want to make sure that we're adjusting that clothing for neatness. So make sure all the buttons line up, make sure the pants are up at the natural waist, not down here. Make sure the toe seams are lined up across the toes. Let them look nice. And where do we put all the dirty items? Should I leave them in the room on the overbed table? No, where should I put them? In the hamper, absolutely. And then if I'm going to end the skill, part of the closing is to give the patient the call light. Which side should I put the call light on? The stronger or the weaker? The stronger. Pay attention to that. And we haven't done range of motion yet. So if we look at this, okay, so remember these are the 11 principles that we have to learn, right? We've learned skill rules. Yay. You just proved to me that you know them. You've learned the opening. You've learned glove rules. We've learned barrier and privacy blanket. We've learned most of linen rules, which we're going to finish up today. And we know the closing. And we're only 1 week in. Today, we're also going to learn a few more. Okay? Good? So it's not hard, is it? It's pretty easy. And we're going to use all of these principles as building blocks to build skills with as we go. So every skill where our patient is uncovered or undressed, this is going to apply. Our privacy blanket rules. Good. Every skill that we need supplies, barrier is going to apply. So we're going to use these as building blocks to make skills with. So instead of learning 21 skills, we're only learning 11 principles, and you now know more than half. So most of the learning is pretty much behind you. We only have a few things left to learn, and then we're just going to repurpose all of those things. Okay? So before we get here, so just bear with me real quick. Before we get here, I'm going to change this, and we're going to go back to class 1 so that I can, I'm sorry, not class 1, class 2. So I can teach you range of motion that we did not get to. Give me a second here. Sorry, guys. Those of you who are joining us online, we will be right back with you. I'm just changing the view. Give me a second. We'll be right with you. We did not drop off. Oh, nice. All right. So give me just a second, guys. I just need to get this set up for you. Give me just a second, guys. There we go. That should work. Okay. All right, so let's go to page 76 in your book. 76 in your book. And we are going to learn range of motion shoulder. This is a skill that I was going to be going over on Wednesday, but we weren't able to get to it. This is a quick skill, pretty easy to learn. We know almost all of the principles involved. We're going to follow the care plan. Every skill starts with the opening. Every opening starts with, we've got to evaluate if we need gloves, and we're going to do the closing at the end. Okay, so we already know all that. What we need to learn is the range of motion specific steps. I have a video on this, and test specific information is at the bottom of the screen. You can see somebody with your level of experience, which is none, should be able to do this skill in 4 minutes or less. You're going to be doing it on a real person, so one of you might be the patient for this. That patient is going to be laying in bed, and there's no documentation required for this. So let's learn what range of motion is and what it's not. We need to know our role here. So when range of motion, which are exercises that are performed on certain extremities, are ordered, we need to understand who's ordering them and why. Okay, the why counts here. We have a whole department geared toward exercises to make people better. That is physical therapy, right? So physical therapy directs exercises to regain function. That G is important. That is not CNA. In fact, physical therapists have to go to school. It's a doctorate degree. They have to go to school for 10 to 12 years to be a physical therapist. How long are we here for? Yeah, 4 weeks. That's not us. Can't be us. 4 weeks, 12 years, no contest. We do not do exercises to make anything better. Not our job. So then why are we doing exercises? Well, CNAs do exercises to retain function. That T is important. Physical therapy regains, CNAs retain. We're not trying to make anything better. We're just trying to keep it from getting worse. So let me explain to you why this would be important. When you are sick, you probably spend a lot of time in bed, right? When you're in a facility, you probably spend a lot of time in bed or in a chair or a wheelchair or just kind of bumming around. Over time, your muscles will become weak. And then when we fix whatever's wrong with you, we send you home with weak muscles. And that can be a recipe for disaster. That means you're probably going to come back in because you fell and broke your hip. That's no good for our patient. So as CNAs, our job here is to keep the patient in the same condition that they're in, to keep those muscles from degrading or atrophy. That's the term when the muscles shrink in size and grow weaker. It's called atrophy. And guys, here's the scary part. Atrophy can start to set in as little as 3 days. So CNAs performing range of motion is actually really important. It's also why we try to get our patients out of bed as much as possible. And you may be asked to walk the patient around the nurse's station a couple of times each shift. Or you may be asked to help the patient to the bathroom and back when you think it's easier to use a bedside commode. All of these strategies are designed to prevent long-term problems. Okay, good? Make sense? Do you guys understand the difference here? Oops. All right, so there's 2 types of range of motion. There's active and passive. Active means the patient does it. We just tell them what to do. So if I ask all of you to stand up, And I ask you to extend your left arm above your head like you're asking a question. So extend your left arm all the way up. Get that elbow nice and straight. Reach for the sky. Bring it all the way down in front of you, not to the side. And then all the way down, all the way. And let's do it again. All the way up. Keep that arm straight. All the way back down in front of you. And one more time. All the way down. There we go. Oh, one more time. Back up. And all the way back down. Good. Have a seat. You guys just did active range of motion. I told you what to do. I made sure you did it properly, going all the way down, getting that elbow straight. But you're the one that did the work, and that's going to give us the best range of motion. Now, all of your muscles are engaged. Okay? But it doesn't always work like that. Sometimes our patients can't do the work themselves, and we are going to move their arm for them, and that is then passive range of motion. The patient is not actively involved. CNAs do both active range of motion and passive range of motion. How would we know which one we're doing with this patient? Care plan. Care plan is going to tell us whether the patient's going to do it or if we're going to do it. So in order to learn how to do this skill, we already know all of our principles involved. We know to follow the care plan. We know to do the opening. We know to evaluate if we need gloves. And we know to do the closing. So the range of motion steps are what we're going to learn here. All of these steps correspond to a testing checklist. If you look at this checklist, you'll see care plan, opening, closing. So there's only 1, 2, 3, 4, 5 steps out of this whole care plan that are actually related to the skill that we're doing. That's why we have to learn all of that. 5 steps. And some of these we already know. We're going to support the extremity near the joints. We've heard that before with pulse. That's nothing new. We're going to make sure that we're lifting from below with a flat palm. That's nothing new either. We learned that with pulse as well. We want to move slowly and smoothly, right? We don't want to hurt the patient. So we want to, when we lift an extremity, we want to make sure that we're not going really fast, just woof, 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 right? This isn't a race. We want to move very slowly, and we want to watch for signs of pain. What would some signs of pain be? Yeah, grunting, groaning, whining, wheezing, anything like that. What about facial expression? When I take a step wrong and my knee gives way, you guys can all tell. How can you tell? Good morning. Yeah, my face. I wince. I can't help it. It hurts, right? So wincing is a sign of pain. Patients telling you, ow, that's a sign of pain, right? We should be monitoring for all signs of pain. If we see pain or hear, the next repetition will go below the level of pain. So if I'm helping a patient with range of motion on their shoulder and I get to hear and I see pain on their face, they wince, they grimace, they turn their head, they do something like that, I'm going to go back to start, and the next repetition will go below the level of pain. We're not trying to fix anything here. We're just trying to maintain what the patient has. But I'm going to go let the nurse know at the end of the scale, hey, I was doing range of motion and got about here, and the patient winced or grimaced or said ow or whatever happened there. You might want to check that out. Okay, good. Questions? Questions? Okay. We want to make sure we're returning all the way to the start position. Range of motion does not count if you don't go all the way back to start. So remember when you were raising your hand and bringing it down, you brought it down to about here because you knew I was going to make you go back up? That didn't count. You had to bring it all the way back down to start before we started again. Remember, what we're trying to do is keep these muscles from degrading. So no shortcuts here. Up and all the way back to the start position, not halfway. Now, there's 3 different exercises that we can do as CNAs. Physical therapy has way more than we do. CNAs are limited to 3. We have flexion extension, which is what you just did. I asked you to extend your arm above your head like you're asking a question, right? That was extension. Flexion is to bring it back down. Flexion and extension are 2 halves of the same exercise. One goes up, one comes down. Okay. Abduction, adduction, 2 halves of the same exercise. One goes out, one comes in. But let me explain to you what abduction, adduction is. When you abduct a child from its family, don't do that. That's bad. Okay. But when you abduct a child, you take it away from its family. When you abduct an extremity, you take it away from its family. Adduct, ADD, means to bring it back or add it to. So abduction, adduction is a side-to-side motion, different than flexion, extension, which was an up and down motion. But if you notice, my hand ends in the same place with both of them. Ends in the same place, but they work different muscle groups. Okay. Good. How do we know which exercises to do with which patients? Care plan. All right. Rotation doesn't have a counterpart, like flexion and extension go together. Abduction, adduction go together. Rotation is just one because we always end where we started. It's a full round motion. Not all joints can do rotation. Only ball and socket joints and articulating joints can do rotation. My elbow will never do rotation. Elbows only do one thing. This is a hinge motion, a hinge joint, up, down. That's all I can ever get an elbow to do. You get an elbow to do something other than this, you broke it. We don't do that, okay? So flexion, extension is up, down. Abduction, adduction is side to side. Rotation is around. Good? You have all of this in your book. So let's look at the care plan. This is going to tell us which exercises to do, and we always follow the care plan. And there's 3 things we need to know on a range of motion care plan. The first is, what joint am I exercising? The second is, what exercises do I need to do? And the third thing is, how many of those exercises do I need to accomplish? So think of this as a recipe. As long as we follow the recipe, the cake is going to come out just fine. This recipe tells us to perform the following range of motion exercise to the resident's left shoulder. So that tells us where. Left shoulder. Should I do the right too while I'm there? No, we should not. We're going to follow the care plan, the whole care plan, and nothing but the care plan. The exercises are flexion, extension. Remember, that was up, down. And abduction, adduction. Remember, that was side to side. Perform 3 repetitions of each exercise. So up, down 3 times, side to side 3 times. The resident is not able to help with the exercises, and that's why it's passive range of motion. So we're going to go in and do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I need to do some exercises on your left shoulder. I'm going to do all the work. Is that okay? Close curtain, wash hands, come back to the patient. Now, as long as they have no open skin, I don't need gloves. If they have open skin or body fluids in the area, do I need gloves? Yes, so I've got to evaluate for that. And then I'm going to do the work, but I need to tell the patient what I'm doing. I'm not just going to grab that arm and start moving it around and they don't know what I'm doing. They'll start to resist because they don't know. So I need to explain this. I am going to lift your arm above your head like you're asking a question. And we're going to do this 3 times. Patient's going to go, oh, I know what that is. That's okay. If I just walked in and said, we're going to do flexion extension of your shoulder 3 times, they don't know what that is. And they will unconsciously stiffen up because they're expecting it to hurt. That's right. So the more information you give the patient, the more cooperative they become. So I'm going to lift your arm above your head 3 times and return it to the bed. Let me know if there's any pain. So 1, all the way back to start. 2, all the way back to start. And 3, all the way back to start. Remember, I'm always supporting from below at 2 joints. Now I'm going to move your arms side to side like you're making a snow angel. And we're going to do this 3 times. Ready? 1, all the way back to start. 2, all the way back to start. And 3, all the way back to start. Very good. Do you have any pain? Everything good? Here's your call light. Hit the red button if you need me. Are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Environment is clean. Open the curtain. Wash your hands. Read the care plan one more time to make sure that we did everything correctly. We exercised the left arm. We did shoulder. We did flexion, extension, and abduction, adduction 3 times each. We monitored for pain. We're good. And now I can say my skill is done. Bless you. Good? Questions? Questions? All right. Okay. So this is our page 77, that tells us our care plan at the top, step-by-step instructions on how to do this. It's got a couple questions here that you can answer to make sure that you got the important points of this particular skill, and there's no supplies required. So give me just a second, and I'll show you this video.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
I'm great. I need to do some exercises on your left shoulder. Is that okay?
Yes.
I'm going to close your curtain and go wash my hands. I'll be right back.
Okay.
Okay, I'm going to do a series of exercises. We're going to repeat each one 3 times each. The first one's going to be a flexion extension, where I raise your arm over your head and back down to the bed, and we'll do that 3 times. Is that okay?
Okay.
I'll do all the work. All you have to do is let me know if there's any pain or discomfort.
Okay.
I'll stretch your arm out here to start. So we're going to raise it above your head and back down to the bed 3 times.
Okay.
Supporting at both joints. We're going to go all the way up and all the way back down. Feel okay?
Yes.
Any pain?
No.
We're going to go up again and all the way back down. That's 2. 1 more. Up and all the way back down. That's 3. Feel okay?
Yes.
All right, your next exercise is an abduction, adduction. We're going to swing your arm to the side and back in. We'll do this 3 times.
Okay.
Like you're making a snow angel.
Okay.
So we're going to go all the way up and all the way back down. That's 1. All the way up and all the way back down. That's 2. All the way up. Feel okay?
Mhm.
And all the way back down. That's 3. Are you comfortable?
Yes.
Can I get you anything, such as a magazine?
No. No.
Okay, your environment is clean. Here's your call light. If you should need anything at all, please let me know. I'll go ahead and open your curtain. And there's nothing else that you need?
No, ma'am.
Okay, I'm going to go wash my hands. Thank you.
Thank you.
After washing my hands, I'll review all the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Sorry about that, guys. Be a little glitchy. All right. Okay, any questions on range of motion shoulder? We're going to learn 2 more range of motions as we go through the program. Range of motion hip, knee, and ankle, and range of motion elbow and wrist. It's the exact same thing, just on different body parts. So we're going to read the care plan. It can be any of those 3 exercises. So we're just going to do the exercises on the body part for the amount of repetitions indicated. Okay. These are super easy skills. If I were looking for skills to do for the test, these are the ones I would want to get. Okay, so Christine asks, when we go into the room and do the opening, how would we know if there is body fluids anywhere before we wash up? Okay, so will we have to look at them and have a peek, or ask someone if the patient has cuts? So good question, Christine. This is, so let me see if I can answer this. Our glove rules say if you're going to touch any body fluids, personal skin, or non-intact skin, right? Those are our 3 criteria. If the answer is definitely no, then you don't need gloves. If the answer is maybe, then you need some gloves, because we don't know, okay? So in the situation that you're talking about, it's probably going to be maybe. But let me kind of go through some scenarios so you can see. If I'm going to take a pulse on somebody, I can see their arms when I'm doing the opening. So I can evaluate that just while I'm doing the opening to figure out if I need gloves. If I am going to do range of motion on the shoulder, again, their arm is visible, so I can see that while I'm doing my opening. But if I'm not entirely sure, because their arms are laying on the bed, if I'm not entirely sure that they don't have something on the underside of their arm, then I can wear gloves because I'm not sure. But remember that we're going to wash our hands before and after. So if we did accidentally touch some body fluids or exposed skin, remember we're washing our hands afterwards. And your skin itself isn't going to let any pathogens through. So as long as you don't have any openings on your hands, you're okay. Does that make sense? I hope that makes sense. Now, if I'm going to do mouth care, I'm going to be in somebody's mouth, I need gloves. If I'm going to be changing the sheets underneath somebody, and I know that they're fully dressed, and I know they hold on to all of their own body fluids like a champ, then I don't need gloves. But if I'm not sure, I need to wear them. Does that make sense? Okay. So if in doubt, you can wear gloves, but remember our glove rules apply. The first thing your gloves should touch is the patient. That's right. And then you have to be careful about what else you're touching in the environment once your gloves are contaminated. Okay. I hope that helps. Let's go to page 116. And this is hand and nail care. So this is going to be our first washing skill. So we've got to learn some washing rules here. So if you look on page 116, you can see all the principles that are involved in this particular skill. We're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves, and we need supplies, so we're going to use a barrier. Linen rules are going to apply because we're using linens. Washing rules and basic cleaning go together. We'll talk about those two in just a minute. And then we need to do the closing at the end, which we already know. So out of all of these principles, washing rules, base and cleaning, and skill specific is what we need to learn in order to learn this skill. At the bottom of the screen, you'll see somebody with your level of experience should be able to do this skill in 11 minutes or less. We're washing somebody's hand, guys. One hand. And they're giving us 11 minutes to get that done. Way more time than you actually need. Don't rush. This is going to be done on another testing student, so you may be a patient for this. That person will be sitting in a chair. So when you're practicing, you can put a live student in a chair to practice this. That way you're always practicing as if it were the test. Charting is not required for this skill. So here are our two new principles that we need to learn to do this skill. washing rules and basin cleaning. We're going to focus on washing rules first. Now, you're going to see this a million times because we have a lot of washing skills that we have to learn. Remember, ADLs is what we do. So ADLs, there's a lot of bathing, right? We do a lot of bathing. So different body parts. So we have to learn washing rules. You'll see if you go to page 112, which is where we're going to learn washing rules, you'll see that we're going to use this in catheter care, foot care, hand and nail care, partial bed bath, and peri care. So we're going to use this in several skills. But in order to understand the principles here, we're going to go to page 113 and talk about this. So all of your notes, are on page 113. There we go. All right. So let's think about how you bathe, right? You get undressed, you turn on the water, you wait for it to warm up, and you get in the shower and you get wet. After you get wet, you put some soap on. You scrub a dub, all the areas you're going to scrub a dub. And then what do? You rinse. Why do you rinse? Yeah, what happens if you don't rinse? What if that soap stays on your skin? What happens? Yeah, you're all soapy, and that's actually going to dry on your skin and make you itch. It can irritate your skin. And if we do that too often, it can actually cause your skin to dry out and crack. So rinsing, pretty important, pretty high on the must-do list, right? You wouldn't think about getting into the shower, putting soap on, shampoo in your hair, and then just jumping out. That would be weird, right? So rinsing is important. Now, you know that. I know that. You're wondering, why is she talking about that? I'm talking about this in detail because for the test, you will forget to rinse. You will. I've been doing this a very long time. And I know how students perform in the test. And students consistently forget to rinse during the exam. Now, what effect does that have on the patient? Uncomfortable. They're itchy. They feel sticky. Their skin is drying out and potentially breaking, which is now a warm, dark, moist area for pathogens. So this is a really important thing for the patient, isn't it? That means the evaluators are going to see it as a really important thing. And if you don't rinse during the test, it is going to count big. Does that make sense? And yet I know that during the test, your brain is like going in hyperspeed, and you will forget if I don't make this a priority for you. So during the test, you're going to remember, you're going to hear my voice in your head saying, whatever we wash, we rinse. Whatever we rinse, we dry. You're going to hear that in my head, in your head when you're testing. And that's a good thing. Okay. But in order to rinse, we need clean water. Right? So when we're getting our water for bathing, we don't put soap in the basin, because if we put soap in the basin, now we have no clean water to rinse with. So basins are no soap zones. We do not put soap in the basin. Whatever you wash, you rinse. Whatever you rinse, you dry. And since we have to rinse the soap off the skin, we don't add soap to the water in the basin. That leaves our water clean. It also means we don't want to put soapy washcloths into that water as well. Okay. So, well, if I'm not putting soap in the water, where does the soap go? How many of you guys shower? Yeah. When you're showering, you probably use something to shower with, a washcloth, a body puff, a silicone scrubby. You have something that you put soap on, right? Same thing with patients. We're going to put the soap directly on the washcloth. We're going to get it wet first. So we're going to wet our washcloth in our basin. We'll put soap on the washcloth, and then we're going to use that to wash with. Good? Questions? That leaves our water clean for rinsing. So we know that to wash, we have to go get water. The problem is that you've done your opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Awesome. Close curtain. Go wash my hands. Get a barrier. Get my supplies. Put them on the barrier. And now I'm ready to get water. So my hands are clean. They've only touched clean things. And now I'm going to take that basin over to the sink, and I've got to put water in it. And I know I'm going to touch the patient in just a few minutes. So do I want to touch that faucet with my bare hands? No. I'm going to use a paper towel to turn that faucet on. Does that make sense? So a paper towel is going to turn the faucet on. But now I've got to make sure the water is comfortable for the patient. And that means I'm going to use the inside of my wrist underneath the water to feel the temperature. It should feel warm, not hot, not cold, just warm. Okay. Remember that faucet is dirty. So we're going to use a paper towel to turn the water on, and then we're going to feel it with our wrist, and it should feel warm. But just because I think the temperature is okay doesn't mean my patient is going to agree. Me, I like my shower scalding hot. If it's not taking off layers of skin, I'm not happy. Okay, I like it hot. My husband cannot stand hot showers. He likes his water cooler. All of you guys have preferences on how you like your water. And they probably don't exactly match everybody else's. So just because I think that water is okay doesn't mean my patient is going to agree. So I'm going to ask them, would you check the water? Because at the end of the day, it's always about the patient. Now, if the patient puts her hand in the water and says, oh, no, that's way too hot, don't argue with them. Don't say, oh, no, it's not. I just checked it. It's fine. If they say, oh, that's way too cold, don't argue with them. Our place is not to argue. Our place is to help the patient. And guys, help isn't help if it's not helping. I'll give you an example of this. A couple years ago, I hired a house cleaner. Come in and clean my house because I was busy. I was writing the book. Okay. Those books take a long time for me to write. A lot of brain power goes into it. I didn't have time to clean my house, so I hired a housekeeper. And I thought by hiring a team of house cleaners that does this every day, all day long, that they would know what to do. I wasn't specific. I was like, yeah, I just need my house cleaned. And when they cleaned my sliding glass doors, they only went up as high as they could reach, which means I had an area about this tall on the top of my doors that were not cleaned, and you could see it when the sun shone through. The floors, when they mopped the floors, they didn't move any of the rugs. You know, the little rugs in front of your bathroom sink, didn't move them. So now I've got dust bunnies all over the edges of those rugs. When they cleaned the toilet, they did not lift the lid and clean underneath, or, the seat and clean underneath. So the bowl was clean, but not the seat itself where my tushy sits. Right? So, yeah, they cleaned, but did they really clean the way I wanted them to? No. So there was a mismatch here of expectations, right? Did they really help me? No, because I still had to go back and do it all myself. And I had to pay them. So was it really help? Okay, help isn't help if it doesn't help. Does that make sense? As CNAs, we are here to help our patients. That's our whole role. So if we're not doing things the way the patient needs them done, are we really helping? Not really. So asking our patient, is the water comfortable, is a big part of making sure that we're helping, not forcing. Does that make sense? But there's another reason that this is important. And it's a much more important reason. And that's what we're going to get into now. As we age, every part of our body ages too. And part of that aging process is going to affect our skin. Have you ever seen a little old person? Have you seen their skin? It looks like roads underneath their skin, like their veins are prominent. You can see them. They actually poke up out of the skin, right? They're very, very visible. Now, look at your arms. Do they look like that? No. So, why does an old person's arms look like that, but mine doesn't? Well, the reason is aging. Underneath your skin, between your skin and your muscles and blood vessels, is a layer of fat. That fat is important. When we're young, that fat layer, pretty thick. Skin layer, pretty thick. Muscle layer, pretty thick. So we got a lot of cushioning there. As we get into middle age, you'll see those layers start to contract a little bit. So now you can see my veins a little clearer than you can see yours because I'm in this category. As I continue aging, those layers will further decrease, and I'm not going to have as much fat underneath my skin. Now, why does that matter? Why do we care? That fat is way more important than you think it is. That fat actually acts as a wetsuit. It covers your whole body, and it helps regulate your body temperature. So, why does this matter? Well, our normal body temperature is about 98.6. There's a range, but this is the average, around 98.6. Anybody ever hear this? Your body temperature? So let's just make it easy. Let's just call it 98. We'll use nice even numbers, right? 98 degrees. If you walked outside right now and it was 98 degrees, how would you describe the weather? Hot. You reach over and touch your partner next to you. They are right now sitting where they are, 98 degrees. We don't really stop and think about that. 98 degrees is hot. This room is not 98 degrees. It's probably about 70. Okay? And yet you guys are all 98 degrees. Well, there's a problem with that because there's a principle: room temperature always wins. Always. If you take ice cream out of the freezer, what temperature, how would you describe that ice cream? Cold, right? Comes out of the freezer, it's cold. Leave that ice cream on your counter for a couple hours. What happens to the ice cream? It melts. It doesn't stay cold, does it? No. It's going to normalize to room temperature. Room temperature always wins. Take a pie out of the oven to go with the ice cream. And when we take the pie out of the oven, we cooked it at 325. We take it out, put it on top of the stove. What is the temperature of the pie? Hot. Now you leave that pie on the counter for a couple hours. Does it stay hot? What does it do? To room temperature. Room temperature always wins. You guys got that concept? Room temperature always wins. That means for your bodies to stay 98 degrees, 98.6, I know, we're making it easy. 98 degrees, that means that your body has to actively create heat because room temperature always wins. The way your body creates heat is by burning calories. The food you eat in your gut is used to create heat. Guys, that's actually the real reason you eat. Yes, it's going to fuel your cells and provide nutrition, but this is a way more important problem, believe it or not. Because if your body temperature falls below 95 degrees, you have hypothermia. If your body temperature falls below 91 degrees, you are dead. Room temperature is about 70. Room temperature is always winning, always trying to bring your body temperature down to it. We can't go below 95. So it takes a whole lot of work for your body to maintain that 98.6 degrees. That is why we eat. This will kill you way before bad nutrition will. Make sense? Got it? So, why am I talking about this? Why is this important? That layer of fat that you have under your skin helps hold that body heat in. So now your body doesn't have to work as hard to generate as much heat because the heat you're generating is being held in by your wetsuit. So what do you think happens when that wetsuit goes away? You feel cold. Anybody ever know an old person? They always complain about being cold. They're cold because they've lost their wetsuit and the body heat that their body is producing is evaporating, going away. This is why a lot of older people retire to Florida because their body doesn't have to work as hard to overcome the cold that we find up north. You'll hear a lot of old people say, "Yeah, I can't tolerate the cold up north anymore." They really mean it because their body has to work so hard to overcome that. But that wetsuit does more than just hold your body heat in. It also helps keep external temperatures from affecting your body temperature. So that wetsuit keeps outside temps outside and inside temps inside. It's important. And when we lose it, it has an effect. Okay. So as we age, the outside temperatures tend to penetrate more effectively. The inside body heat tends to radiate out. So a lot of our older people will keep their houses warm. They'll also be wearing sweaters. They'll tell you they feel cold. That's not going to be your perception of the temperature because you're wearing a wetsuit. Okay. You're going to walk into grandma's house and go, "Oh, grandma, it is hot in here. Oh, what's wrong? Is your AC broken?" She's like, "Oh, no, it's fine. It's fine." You're like, "No, it's not. What's wrong with grandma?" And it's because that's how they're regulating their temperature. Good. So that tells you that you and that patient do not perceive temperature the same way. So when you check that water temperature with the inside of your wrist, remember that you are feeling that through a layer of fat that your patient does not have. So you feel the temperature, it feels warm. You take the bucket over to the patient and you say, "Will you check the temperature?" When they put their hand in there and they go, "Oh no, that's too hot," They're feeling something you're not because they don't have that layer of protection. Don't argue with them. Just say, "Oh, I'm so sorry. Let me go cool it down a little bit for you." Okay. Good? Makes sense? Let me tell you one of the worst, how do I put this nicely? So I was in a nursing home at the nurse's station many years ago. And the shower room was down a hallway off to my right, about 4 doors down. Shower room. And hold on. I'm sorry. Hold on one second. I'm sitting there charting. I'm on the phone with the doctor. I'm taking orders. And down the hallway, I can hear a patient screaming, "No, stop. No." I mean, just screaming. So I hang up with the doctor and I go down there to find out what's happening. And as I open up the shower room, steam is billowing out. My glasses fogged up right away. Had to wait a second for everything to clear so I could see what was going on. And the patient is actively pushing the CNA and hitting and kicking and combative. And I'm like, "Oh my gosh, what's going on?" And I'm like, "Stop." I immediately turn the water off. "What's going on here?" And the patient's like, "It's too hot." And she won't listen. It's too hot. And the CNA is saying, "It's not too hot. It's fine. I checked it." All full of attitude. Now, the steam gave me all the information I needed to know. We've got a room full of steam. You've got a patient yelling that it's too hot. What more do you need as a CNA to question your actions? When the patient says no, we need to believe them. It's their body, not our task. And the CNA's defense was, "Well, it's the same temperature I use for everybody." Well, she's not everybody. This is clearly not comfortable for her. At what point were you willing to take her wishes into consideration? And the CNA told me, "You treat them all the same." Okay, I don't know where you went to school, but you need to get out of here, like right now. I will talk to you later. And I finished cleaning the patient and I got them all bundled up and back to their room and dressed. And then I went and talked to that CNA. And it was not a pleasant conversation because I suggested that this may not be the right career for her. And I did write her up. Because had that been my grandmother, this would have ended a whole lot different. I probably would have been in handcuffs. We don't treat people like that. Does that make sense? Your perception of temperature is going to be different from your patient's. Help isn't help if it doesn't help. Okay? Make sense? So, a very important checkpoint is to check the water temperature, but have the patient check it as well. If you forget that checkpoint, you will fail this test. And I'm okay with that. Make sense? Remember, it's not just, "Oh, I forgot one step. Why did they fail me?" That's not what the test is about. The test is about how are you helping these patients. Okay, good. All right. So, whatever we wash, we rinse. Whatever we rinse, we dry. These 3 steps have to be completed. And which one did I tell you you'll forget? Rinse. So now that you're aware of it, you're going to be really, really conscious of, I need to rinse. Remember that. So this is a picture of soap left on skin. Look at that. That's what happens when soap is left on the skin and it's looked at under the microscope. That is itchy and irritating and horrible, and your patient will dig at it and scratch at it, and we shouldn't do that. So if the water gets cold or soapy, we need to change it out. That just makes sense, right? And we don't want to get our surfaces wet. So that's what the barrier is there for. That's why we have the absorbent side facing up. If we happen to spill some water, it doesn't drip on the floor where it becomes a slipping hazard. So make sure that you're not getting your surfaces wet. If we're going to put lotion on, we warm it up in our hands and then we wipe off the excess. So we're doing hand and nail care. If I put lotion on that hand and I don't wipe off the excess and she goes to pick up a cup of hot coffee, all of that excess lotion on the surface is going to cause that coffee cup to slip. And then the patient could get injured. So that's a big step, making sure you wipe off the excess. Now, anytime we use a basin, we have to know how to clean it. That's where basin cleaning comes in. But it's important to understand that in healthcare, as a CNA, we're not looking for sterile. We are not looking for sterile. We're just looking for clean, just basic clean. When you brush your teeth in the morning, you probably just rinse out the big globs of toothpaste out of the sink. You don't spray it down with a disinfectant cleaner and put on sterile gloves and wipe it all. You don't do that. You just get the big globs out. That's all we're doing with basin cleaning. As a CNA, we rinse it, we dry it, and we store it. That's it. Okay? So basin cleaning, rinse, dry, store. Get the big globs out. That's what we're looking for. But we had to create a process for this that would allow for disinfection if we needed to. Because there are some times that we are going to have to disinfect. If our patient is on chemotherapy, we have to disinfect everything because we're obliterating their immune system, right? If our patient has HIV and has no immune system, we've got to disinfect. If the patient has a communicable disease, we have to disinfect. So the process that we're going to learn allows for a disinfection step. We're not going to use it for the test, but the process allows us to add that step in without having to change everything. Good? This basin cleaning is going to be found in a whole lot of skills. We're going to use it with bedpan, denture care, catheter care, drainage bag, foot care, hand and nail care, mouth care, partial bed bath and peri care. We're going to use basin cleaning a lot. And you're going to see it a lot. So if you don't get it the first time, it's okay. You're going to see it again and again and again and again and again. So this is covered on page 91. You have all your notes there. And when we're cleaning basins, first thing we have to do is empty them. And it's really simple. Just put them where it normally goes. I mean, if you're dealing with body waste, like urine or feces, where does that normally go? In the toilet. If you're dealing with vomit, where does it normally go? Toilet. If you're dealing with bathing, that goes in the sink. Okay, good. Okay, once we've emptied our basin, we're going to rinse it. We're going to empty the rinse water wherever we dump the stuff. So if it was urine or feces, we're going to empty the rinse water in the toilet. If it was bathing, we'll empty the rinse water in the sink. If it's mouth care, we'll empty the rinse water in the sink. Because I don't know about you, but I do not brush my teeth over the toilet. Remember that basins are single patient use. When you go into the hospital, you get something called an admissions kit. Has everything you need. Basin, emesis basin, cup, pitcher, all of that. That is yours. Only yours. We don't share it patient to patient. In fact, you get to take it home with you if you want to. You paid for it. So it's single patient use. So simply rinsing it, drying it, and putting it in the patient's drawer is fine because that patient's the only one that's going to use it. Okay. The problem is if we start getting more basins for that patient because we don't want to clean anything and we just want to throw it away, that patient is charged for that. Have you ever been to the hospital? Did you get a bill? Nothing in a hospital is cheap. Those basins run about $36 a piece. Emesis basins are about $28. Toothbrushes about $14. Tylenol about $30 a piece. Everything that's used in a clinical setting is going to cost the patient money. Now, you don't know that when you get your bill. You just get a bill. It tells you your contribution. They bill the insurance. Your contribution is $2,192, and you call and make payment arrangements, whatever. But you can ask for an itemized bill. You are allowed to do that. They have to account for absolutely everything that they use on you. And you can dispute items. Why was I charged for 12 basins? One is all you needed. And you can successfully have those things taken off of your bill. Now, as caregivers, if we are making those decisions for the patient, I'm just going to throw your basins away and get a new one each time, you're costing them money. And if they dispute it and win, you've cost your facility money. Where do you think your next raise is coming from if you're costing the facility money? We've got to be better about this. Rinse, dry, store. Disinfect when appropriate. Okay? So if we do have to disinfect, this is how we're going to do it. We're going to empty it where it normally goes. We're going to rinse it and empty the rinse water where we put whatever the stuff was. Then we're going to set it down in the sink, because you can't hold a basin with soiled gloves while you're disinfecting it. You can't touch it with soiled gloves while you're spraying it. So we're going to set it down and spray it. Now, we still have soiled gloves on, so we're going to use a paper towel. We don't want to touch that clean basin with dirty gloves, so we're going to use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and one more to get our supplies and open the drawer. Because remember, your dirty gloves should not touch this drawer. So I know it sounds like a lot. You're going to see this a million times. Don't really stress about it yet. Okay. But we're going to do every step of this for the test except spray. So we're going to empty it, rinse it, empty it, set it down, pick it up with a paper towel, dry the inside, dry the outside, and use one more paper towel to get our soap, our lotion, and open the drawer. Okay. You're going to see that in this skill. I just want you to be aware of the steps. We'll be going over them again and again as we go through the program because we use this a lot. After we're all done, we'll throw those paper towels away. You're going to see basin cleaning a lot. Everything is cleaned the same way. These are the steps. They're in your book as well. So now let's go ahead and take a break, and then I'm going to show you this skill, hand and nail care. But I've got to go over a few things. So let's come back at 10 after, please.
Not Johnny.
Thank you.
Wait a minute. I can talk to the HR. I can talk to HR. What's your name? I'm gonna put the name here, okay? I'm gonna tell that, how did you go to Indeed? Okay. I'm gonna put the name here, okay? So that I can tell the HR, because that's not. Also, they said, maybe you know someone, just tell me the name so that I can go to Indeed and choose. Let's just try. Your name is
Oh, it's
Slip.
Lacey.
Oh, that's Stacy. L-A.
CEY. EY.
And then your family.
W.
Your family is R, I, E, G. Like that. I brought later. And future 11. I'm gonna tell her that you ordered Indeed and you applied for activity support. It's just so easy. You really love it. For the supervisor, just go with it. You know.
Well, I like to look she like all of it. So yeah, I like it. I don't like going in that one. They were just like, oh,
Go that way.
I don't know what the option. They're probably mad at me because the corner.
Oh, yeah, yeah,
They
yeah.
were mad because shot. I mean, they wouldn't even say anything. Like, the policy that said, well, it didn't say anything. They hadn't wrote it yet.
I remember you said that, but our RN, our curriculum activity, so just you don't have any vaccine things that
Yeah, see, they were all for it.
Yeah.
And I'm like, it was too, it's like, I don't know if I want that. Well, just let me decide if I want that.
because that's our freedom, but I don't want it, so I don't want it. Even the cousin of my husband, she's an emergency nurse. Okay. Professional now. She's an emergency nurse. She said, no, I will not have any vaccine of this.
And it's so new, I don't really know about it. And then you get, then after they get people, then they come up with the side effects. They don't tell you what after.
I will not be around next Wednesday. Appointment. I'll be back Monday. So that will be easy, right? I mean, you can say, I really don't like online because it's really different, but it's actual, you know, it's really, really different. I did online class, online for CPR.
Yeah.
I passed, girl, I passed, okay? I passed, but I was like, there was someone in CPR that it's really different. Yeah, I passed, I was perfect, but I was like, actual, I don't know. I'm not, you know?
Yeah.
But my coworker said, oh, we did the actual, we do that, and that. Really? Right?
I did it online. So I did in person online and then the day after. And I didn't feel good about it for 1 year. Because he actually made us like practice.
Yeah.
The other one, they just like, they kind of just whatever.
Yeah,
They don't really care if you show them or not.
right. Tourists for that. Like last time we had a diagnosis certificate. We were like, she did it on her. Yeah, Queenie. And then they're, oh, this person has a diabetes. Oh, Queenie, this is I said, no, hey, you do. Because I don't have actual experience, you know?
Right.
It's really different.
But your hands-on is better than.
Yeah, exactly. Yeah. So,
Okay, any questions so far?
So for hand care, what if they're like having an IV? Would you still do it the same way?
So if the patient has an IV in their hand, you would be instructed to just do hand care on the other hand. So let me explain to you why we're going to do hand care. It's not necessarily to wash the patient's hand, although that's what we're doing. When you think about yourself for a second, you probably largely ignore your nails and they grow. And then they get too long and you clip them down. And then you ignore them and they grow. And they get too long and you clip them down, right? If they get too long in a patient care setting or patients, then they could, scratch themselves. They could accidentally scratch you. The nails will probably get ragged and jagged. And, there's a lot of problems with that. So hand and nail care is done primarily to keep the nails at a convenient length and to get rid of any ragged edges or sharp areas to keep the patient safe. That's the main reason that we're doing hand and nail care, is to clean under the nails and to file the rough edges to keep them at a manageable length. A lot of preventative maintenance would keep us from having to use nail clippers. CNAs don't use nail clippers. Nail clippers are advanced machinery that you're not allowed to touch. And that's because the risk of cutting a patient's skin is pretty high. Nail clippers are sharp. So if we soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, and file the rough edges, then we never have to use nail clippers. Okay. So if the patient has an IV, we're not going to be doing hand and nail care on that hand because we don't want it submerged. So once again, we would follow the care plan that'll tell us what to do. And this particular care plan is going to tell us to do hand and nail care on one hand. We get to pick which one for the test. But that's, the whole purpose is to learn how to follow that care plan. Okay. The patient has an incision on one side, on one hand, we're not going to do hand and nail care on that. Remember that CNAs do normal. Anything outside of normal is whose responsibility? Yep, the nurses, not ours, not our job. So we're going to do hand and nail care on patients that have normal hands. If it's not normal, then the nurse has to do it, or they have to show us how they want it done. Okay, good. Questions? So this is what we're going to do with hand and nail care. We're going to soak the hand in a basin. We're going to take it out and place it on the towel to wash. We'll put it back in the basin to rinse. We're going to take it out and put it on the towel to dry. Once we've done these steps, we're going to use the slanted end of an orange stick to clean underneath the nails. But if I clean under one nail, I don't want to take that dirt and put it under the next one. So I'm going to wipe it off on the towel before I move on to the next one. And then we're going to, once we've cleaned under those nails, then we're going to file the nails in one direction only. Now, this is a change for you, and it's very important. Remember how we talked about aging, right? Aging, how it affects the skin. Aging also affects the nails. Nails become very brittle. They become thinner. They tend to peel. But most importantly, they're likely to split up the nail this way, up the nail if we don't take care of them properly. Now, you guys, you still have very good skin, good nails, good keratin and, all the things that make your nails strong and healthy. So you probably don't realize this. You take a emery board and you do something like this, right? Back and forth really fast to get those rough edges off. Don't do that with an older person because what that does is it pushes and pulls that nail by going back and forth really quickly. It pushes and it pulls. Now, patients that are older and are at risk for the nails to split, when you push and pull, that's exactly what happens. That nail will split all the way to the cuticle. So when we file, we don't go back and forth. We go in one direction only toward the center. So when I'm going to file an older person's nail, one direction toward the center and then across the center, not back and forth. Okay, we don't want to put that longitudinal stress. After we've filed the nails, then we're going to warm lotion up in our hands, apply it, and wipe off the excess. Those are the steps of hand and nail care. Good. Now, if you notice, that follows our washing rules. Okay. Good. So washing rules we're going to use for lots and lots and lots of skills. So let me show you this video because it's got really good close-ups of hand and nail care so you can see exactly how I wash, rinse, dry, how I clean under the nails, how I file, and how I apply lotion. Notice for this skill, we're going to start with the opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Go through all of those steps, get our barrier, wash our hands, get our barrier, get our supplies, get our water by using a paper towel, turn the water on, checking the temperature, having them check the temperature, put the hand into soak, take it out to wash, put it back into rinse, take it out to dry, clean under the nails, file the rough edges, warm the lotion, apply it, wipe off the excess, do our closing. Okay. This is a longer skill. Remember, somebody with your level of experience, should be able to complete this in 11 minutes or less. The video does not take that long. All right, here we go.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
ma'am.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. You're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers, and then I'm going to turn your hand over and dry the palm of the hand as well. Okay, now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges.
Sorry, Mom.
And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions?
I don't understand the two washcloth. It should be under. I mean, put to the water, and then the other one is to scrub.
So one washcloth is to wash, one washcloth is to rinse.
Okay.
So we're going to put both of them in the basin to get them wet. We're going to take one out, bring it out, and then put soap on it to wash the hand. And the other one will be used to rinse the hand in the basin. Okay.
Well, I can't put the rag.
You don't want the soapy, the washcloth that you put soap on, you don't want to put that back in the basin because then it's going to get your rinsing water all soapy.
So we just leave it on.
Just leave it on the barrier. And at the end of the skill, you're going to take all of your dirty linen and put them in a hamper. Okay? Good? Questions? All right, moving on to changing an occupied bed. This is on page 141. Christine asked, would we stand for this, or I think it's supposed to be sit? If you're talking about hand and nail care, Christina, it's whatever you're comfortable with. You can stand if you want. You can pull up a chair and have a seat for hand and nail care. Either way is fine. There's only one skill that you're required to sit for. We'll get to that a little later in the program. But you can pull a chair up if you want to. It's not an overly long skill. I know you have 11 minutes to do it. But, you know, by the time you get your opening and your supplies and all of that, and then you do your closing, the skill itself really only takes about 3 minutes. So going and finding a chair and pulling it up and having a seat, you can if you want to, but it's not really necessary. You're really not standing there that long. Okay? But yeah, if you want to, you can. All right, so changing an occupied bed, page 141. If you look at the principles involved, they're listed here. They're detailed here. We know skill rules. We know the opening. We know glove rules. We know to use a barrier if we're going to have supplies. We know how to use a privacy blanket. We've learned most of linen rules. We're going to finish those up in just a minute. We still have to learn scoot and roll. This is a new one. And we know the closing. So we're going to learn scoot and roll now. Okay, we're going to learn scoot and roll now. So, I'm sorry, let's finish up linen rules first. We've learned most of linen rules. We skipped 2, so we're going to go back and fill those in. Okay, so the one that we haven't learned is clean rolls toward you, dirty rolls away. And we're going to use this quite a bit in several different skills. But when it is related to occupied bed, we're talking about the sheets. So the patient is laying on a sheet. We've got to change that sheet out from under them with them still in the bed. That's what changing an occupied bed is all about. Now, I don't know about you, but in my house, when I'm changing the sheets, I make everybody get out of the bed. Right? Makes it easier. And that works if somebody can get out of the bed. But what if they can't? If somebody is stuck in bed, if they can't get out of the bed, we still have to be able to change the sheets around them. Okay? So let me explain to you how this works. If we have a sheet on the bed under the patient, and that sheet is soiled, and we're going to put a new sheet on the bed and take that soiled one away, we have to have a way of making this happen. Now, I don't want to put the new sheet on top of the soiled sheet because then it can get soiled. So, the part of the sheet that the patient is laying on is what I want to try to avoid. So, if I roll this one toward the patient, now it's just the underside of the sheet that's facing up. If I roll the clean one toward me, it's the underside of the sheet. So then I can put the clean sheet underneath the new one, and I don't have direct transfer. Does that make sense? So the way that we remember this is clean rolls toward me, dirty rolls away. Good. So when we're changing an occupied bed, let me make these a little bigger so you can see. When we're changing an occupied bed, with someone in it, we're going to roll the dirty sheet toward the patient and tuck it up underneath them. So they're kind of holding it in place. Then we're going to take the clean sheet and roll it toward us and tuck that up underneath the dirty. And then we'll go around to the other side of the bed, have the patient roll, and we're going to take that one away and smooth out that one and have them back in the middle. And now they're laying on a clean sheet. Okay, so clean rolls toward me, dirty rolls away. Questions? Questions? All right, while we're doing this, we don't want anything to touch the floor. We don't want a clean sheet to touch the floor. We don't want a dirty sheet to touch the floor. We don't want any sheets to touch the floor. So we've got to be really careful when we're doing this that we're attaching the ends of the sheets to the bed so they don't slip off and touch the floor. For the test, if your linens touch the floor, you need to address it. You need to say, my linen is contaminated, I need to go get a new one. Okay? They'll probably tell you, just proceed, thank you. And they won't make you go get a new one. But if they don't say that, stop, remove the dirty sheet, put it in dirty linen, go wash your hands because you can't reach into a clean supply cabinet with dirty hands. So go wash your hands and get a new sheet. Okay, good? Does that make sense? So those are the last 2 points that we had not learned on linen rules. We learned linens must not touch uniform. We know that. We know we have to have clean hands to get our linens. We know that. We know not to shake or snap linens. We know that. We just learned clean rolls toward me, dirty rolls away. And we're not going to let anything touch the floor. Not clean, not dirty, nothing. So that's the rest of linen rules. Pretty easy, right? All right, so now we're going to move on. Oh, see, this is why I have these. Okay, so linens can't touch the floor. Now, when I'm at home, changing the sheets on my bed at home, I take those sheets off the bed and I throw them on the floor. That's what I do. That's probably what you do. Sheets come off the bed, they go on the floor. Put the new sheets on the bed, you bundle up the old sheets, take them to the laundry room, throw them in the washer, right? That's how we usually do this at home. But I just told you that nothing can go on the floor. Not clean, not dirty, nothing can go on the floor. So we can't do in a clinical setting what we do in a home setting. It doesn't work. So we have to have a new method of doing this. And our new method is, in most cases, a hamper. We have one here. So when you take the sheets off the bed, you bundle them up and you put them right in the hamper. Now you always want to bundle them up. You don't want trailing edges that can contaminate other surfaces as you walk. You want control over your dirty stuff. So bundle them up and put them right in the hamper. And for the test, you will have a hamper in close proximity to the bed. Yay. But in a clinical setting, you won't. We don't keep dirty things in patients' rooms. The hamper is usually out in the hallway or in a soiled utility room. Remember we talked about that soiled utility room thing? It's either in the soiled utility room or might be out in the hallway. Well, you're not going to take the sheet off the bed and leave the room to go put this thing somewhere. So you got to have somewhere to put it. And I just told you, you can't put it on the floor. So where do we put these dirty linens that are coming off of the bed? Well, in a clinical setting, you will have a bag. It's light blue, usually stamped with soiled linens on it. You'll get one of those bags and open it up, and you can put the linens right in there. You can also, if you don't have one of these hanging around, you can grab a chucks and put in on the floor and put your soiled linens on the chucks. The whole point is the soiled linens don't go directly on the floor. Okay, so for the test, we're going to use the hamper that's right beside the bed. Or it could be a laundry basket at the end of the bed. Either way, we're going to use what's there. In a clinical setting, we're going to use a linen bag or chucks to keep our linens off the floor. Good? Make sense? All right, now there's a little caveat to this, especially when we're using these. In a clinical setting, All of these things are going to be sent to laundry. Now, in most cases, laundry is not going to take these sheets out and shake them out. Remember, we don't shake or snap anything. So nobody's going to check to see if there's anything in these linens before they go into the washer. This is important, especially if we're using one of these bags. Anybody aware of Tide Pods? You know, the little pods you just throw in the washing machine and they dissolve, right? Well, before Tide Pods, way before Tide Pods, like 20 years before Tide Pods, we came out with these bags. This is the original Tide Pod. Built into this bag is the laundry detergent. These bags actually disintegrate in the laundry. So when you put stuff into these soiled linen bags, there's a very good possibility that the entire bag will be put into the laundry machine to be washed and dried. Commercial laundry. Why do we care? Well, as CNAs, that makes us responsible when we're taking stuff off the bed to make sure that there's no dentures in the sheets. There's no hearing aids. There's no cell phones or remote controls or anything that could get ruined in the laundry. We're the last stop. So that's important for us to remember when we're especially changing an occupied bed, because things can hide under the patient. We need to watch very, very carefully for anything foreign that could get tangled up in those sheets and get ruined. On average, one hearing aid, roughly a month, gets washed in a clinical setting. Hearing aids are about $5,000. That's a lot of money. Can you guys come up with an extra $5,000 in your budget? Either can your facility. So we've got to be better about this, okay? Dentures, even worse. Even worse. So does that make sense? All right. All right, so soiled utility rooms, we talked about this last week, but soiled utility rooms are special rooms in a facility that are only going to accept soiled items. So we don't want to take clean items in here. But when we're done changing the sheets, if we put them in a bag, this is where the bag goes. Don't leave it in your patient's room. Remember, we don't leave dirty things in the patient's room. This is where the bag would go in a clinical setting. Take it into soiled utility. Unless your facility has another routine, and that would be in the policy and procedure manual. Okay. Now, there's another thing. We talked about this last week, but I want to reiterate this. This is tested on the state exam. If you take too many of anything on the test, you have to discard it. You have to put it in the hamper or dirty linen bin, whatever they're using at the testing center. Do not leave them in the patient's room. Super important. Because anything that is left out of our sight cannot be considered clean. We can't use it later. That is a testing checkpoint. So that means that for the test, you actually have to learn your supplies. You have to learn how many washcloths you need for hand and nail care, how many towels, how many washcloths you need for partial bed bath, and how many towels, how many sheets you need to change an occupied bed. You have to be aware of your supplies. Now, they're all in your book, in the skill at the bottom of the skills page. So turn your page, turn the page of your book. You'll see making an occupied bed, and at the bottom of the page, you'll see all of the supplies. This one's pretty easy. You need a top sheet, bottom sheet, pillowcase. We need a privacy blanket to keep the patient warm because they'll be uncovered during the skill. You may need gloves if they're not fully dressed or they're leaking something, but for the test, your patient will be fully dressed and leaking nothing. So you can get away with doing this without gloves for the test. That's okay. But you need to learn your supplies for your skills. Now you can make flashcards to learn this. Perfectly okay. We also have flashcards, and these flashcards have the principles. Remember the principles that we've been learning? Right? On the back is all of the principles. On the front are the same review ones that we see with blanks to make sure that you know them. We have the supplies for every skill, and we have the abbreviated steps for every skill too. So this makes a really good study tool for you. And they're only $14.99 while you're enrolled in the program. After graduation, they go back up. Okay. So these are available for you, or you can make your own. But you do need to learn your supplies. So you need flashcards of some kind. Okay. So remember, with linens, we use it or lose it. Now we do need to learn one more principle, and this one is actually pretty easy. Scoot and roll tells us that the patients must be in the middle of the bed at all times. That's it. That's really it. Patient must be in the middle of the bed at all times. But we need to kind of go over each one of these in a little more detail, because each one of these is important. The first is you may not have side rails in all settings, because side rails are a restraint. Side rails are a restraint. If you have a child, you put them in a crib, the whole reason they're in a crib is to keep them from wandering, right? To keep them safe. You don't want them rolling out of bed. You want to keep them safe. But at some point, after they're about a year, year and a half old, they don't stay in that crib. What do they start doing? Yeah, crawling and climbing out. Now, if you've got a small child climbing over the side of a crib, you aren't keeping them safe, are you? Because it's a way further drop. So we take that crib away and we put them in one of those little toddler beds. It's really low to the ground, and that's when they learn to sleep in a bed, right? So that tells us that human beings from a very young age do not like to be confined. And if they are confined, they will find a way over the obstacle, which increases their risk of injury. This is, so we'll come back to this. Hold on. Where is it? Where is it? Do I not have it on here? Oh, I don't have it on here. Okay. So this is, the side rail is an obstacle. If you put side rails up on a bed, your patient, if they want to get out of that bed, will climb over the side rails. They will. And that increases the risk of injury. And side rails actually kill a lot of people a year. The thing is, we don't need side rails. We just don't. As long as our patient is in the middle of the bed at all times, we don't need side rails to keep them safe. Now, the problem is that when we turn a patient onto their side, you think about this, right? They're on their side, but they're near the edge of the bed. And that actually doesn't happen unless you let it happen. And I'm going to show you why in just a minute. Using side rails for safety is dangerous because, as you can see, when this person tries to get out of bed, they're going to have to go between these two sections, which means body parts can get caught. They can end up strangling themselves. They can break arms and legs. These are very dangerous and can only be used with a doctor's order. They can only be used with a doctor's order. Side rails are a restraint. A CNA is never, ever, 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 ever in any setting allowed to make a side rail decision. Ever. Now, this is a legal principle because all of you as adults have freedom of movement. If I were to pick on you and tie you to that chair right now with your arms and your legs tied to the chair using zip ties, that is false imprisonment. Doesn't matter that I'm the teacher, an authority figure, a nurse, or anything else. If I tie you to that chair against your will, that is false imprisonment. And I should go to jail for that. There are only 3 types of people on this planet that have the ability to interfere with your freedom. And 2 of those are temporary. One of them is, of course, a law enforcement officer. They can put you in handcuffs and put you in a cell and restrict your freedoms. They have to have a good reason, but that's temporary. If a law enforcement officer puts you in handcuffs and puts you in a cell, who do you get to go see? A judge. That is correct. And the judge is the one that will decide longer term what happens. Usually, it's going to be in addition to a jury of our peers, right? So it's not just one person responsible for your well-being. It's a whole bunch. It's a panel of people that are going to decide. That's fair for you. That means that one person on a power trip can't restrict your freedoms forever. Make sense? Okay. So if you're arrested, that's temporary. The judge has to make it more permanent. Good. Now, the other person that can temporarily restrict your freedom is a doctor. And it has to be for a good reason, just like law enforcement. They just can't snatch you off the street, throw you in jail because they want to. They have to have a good reason. But even that is temporary. Who do you think is going to be able to make that longer term? Same person, a judge. Okay, a judge has to remove the patient's rights, basically declare them incompetent. So law enforcement can temporarily detain you. A doctor can temporarily restrain you, but a judge is the one that has to make it longer term. Did I say CNA anywhere in there? Did I say nurse anywhere in there? Did I say social worker anywhere in there? So it's either law enforcement or doctor. CNAs are never allowed to make a decision to use a side rail, even in the name of safety. Do you guys understand that? This is super important. You cannot use a side rail without a doctor's order. Okay? Now, there's a difference between side rails and positioning rails or half rails. Let me come over here to show you. So this, can you see it? Yeah. This is a positioning rail. It doesn't impact the patient's ability to get out. They can, the area for their legs is open. They can get out. They can go anywhere they want to. This is not a restraint. This has handholds that allows them to boost themselves up in bed, turn over, reposition. This is a positioning rail. If I put this one up, this is now a side rail because it restricts the patient's ability to get out of bed at will. We provided an obstacle for them. This can be used. It's not a restraint. But if we add this one in, together they become a restraint. You guys understand that? So in most settings, these aren't even on the bed. Not even there. Not even there. So when we get an order for side rails, maintenance usually has to come put those up. And the reason is we can't trust you. We can tell you all day long that you're not allowed to use side rails without a doctor's order. But night shift, weekends, you'll throw patients in bed, put the side rails up, dose them up with Benadryl so you can go play gin rummy in the back break room. We can't trust you. So because of that, we take them off the beds. Good? Make sense? Let me explain to you why you don't need them though. And you don't. Just got it. Okay. So I need somebody to lay down on their back in that bed. Somebody, anybody. I'll just do it manually. Anybody. I need a body. Anybody. So I need you to lay on your back in the bed. I'm just going to take this down so that everybody can see a little better. All right. Where did he put himself?
In the middle.
Did I tell him to do that?
No.
Now, he knows this is temporary. It'd make way more sense for him to be on the edge because he's ready to get up, but that's not what he did. Why did he put himself in the middle? Yeah, because that's where he feels safest. I did not have to tell him to do that. You do not have to tell your patients to do that. They will automatically place themselves in the middle of the bed. You guys get that? Okay. Now, if I need this patient to be on their side in bed, say I'm going to work over here and I need him on his side, and I ask him, can you roll onto your side so you're facing the window for me? He didn't roll. Did you notice I asked him to roll on his side? He didn't roll. What did he do? He shifted. Yeah, he scooted. Yeah, he didn't roll because if he rolled, where would he be?
On the floor.
Yeah, or at the very least, super near the edge of the bed where his body's saying like, no, thank you. That's a little too close for comfort. So instead, he shifted. So he's still in the middle of the bed. He's just facing a different direction. I didn't tell him to do that, did I? He did it automatically. You do too, by the way. You do too. So when we are working with patients that can follow directions, they will do this automatically. But if they can't follow if we have to move them, I'm not just going to roll him on his side because he would be too near the edge of the bed. Instead, I'm going to do what he did, but I'm going to do it in 2 steps. I'm going to scoot his whole body toward me and then roll it so that after the roll, he's in the middle of the bed. So this is called scoot and roll. Scoot toward me and roll away. We always roll a patient away from us, though. We remain behind, the patient's behind. Always scoot a patient or roll a patient away from you. And the reason for that is because when we're on our side, most of our weight distribution is back here. Gravity will always try to pull you onto your back, always. So if I'm here in this position and gravity starts to pull him back, I can very easily stop that. I'm in the right position. But if I've rolled the patient toward me and gravity is trying to pull him back onto his back, I have no control over that because I'm way too far away from that area. That means I'm going to be straining my back to stop that. But more importantly, as I'm reaching, I could lose my balance and fall on top of him. We never roll a patient toward us. There's another reason that we don't roll a patient toward us, and there's no nice way to say this, guys, but you never want a patient eye level with your crotch. Okay? You never roll a patient toward you. That's not good. If your patients have been the victim of any type of sexual abuse, that's a triggering event. And they can become combative and you'll never know why. Good? So the patient must remain in the middle of the bed at all times, regardless of whether on their back or their side. Thank you very much. So that is scoot and roll. All right, so you're not going to have side rails in all settings, and if we do, we still need a doctor's order. Have the patient scoot towards you before rolling away, remain behind the patient's behind, and the patient must remain in the middle of the bed at all times. Any questions on scoot and roll? Side rails don't do what you think they do anyway. They're going to make patients weaker because the patients are not moving around. Their muscles are going to atrophy. Their bones are going to get less dense, weaker, more full of holes. Their digestion suffers. Their respiration suffers. Their mental capacity suffers. The immobility causes a lot of really, really bad effects in the patient, really bad. So we don't want to use side rails because our patients end up way worse. They're not the safety thing that you think they are. So remember, the patients need to remain in the safe zone, which is in the middle of the bed, especially after they've been turned on their side. So we'll scoot them toward us, and then roll them away so they're in the middle of the bed after the turn. Good? Questions? Let's talk about bed position real quick. There's 3 different bed positions we need to be aware of. There's head of the bed that puts the head of the bed up. There's foot of the bed that raises the feet. And then there's the entire bed. And we talked about this on the first class, okay? So the entire bed must be in the low position at the end of the skill. The head of the bed and foot of the bed, whatever the patient wants at the end of the skill. Now, sometimes we do have to adjust the head of the bed at the beginning of the skill for safety if we're feeding a patient or brushing their teeth or something like that. But at the end of the skill, it's always safety. Entire bed is not. Now we're getting ready to change the sheets. And that means that I'm probably going to have to bend a lot to change these sheets. I'm short, I don't have to bend that much, but some of you are taller. You'll have to bend more. You can raise the bed up to a comfortable height to do this skill. You can. There's nothing wrong with it. But what do you have to remember to do at the end of the skill? Put it back down, and chances are you'll forget because now you're on a roll and you just want to get that closing done. So be careful if you put the bed up. It's not a testing checkpoint. You don't have to raise the bed. We don't want the patient lying on the bare mattress. It's just ick. So make sure there's a sheet under them. All right, page 142 gives you your step-by-step instructions for the skill. It's also continued on to page 143 because this is a longer skill. And it also talks to you about how to use a draw sheet. Now, we're not going to get into draw sheets in this class, but I would read that section because you may need to know that for the written test. It's not used on the state exam. All right, so let me show you this skill. Has good close-ups, and then we're going to get into blood pressure.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. A bottom sheet. And a pillowcase. And a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the 2 corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient. Tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, Spread it out on the mattress and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soil sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, any questions on that? Any questions? No? Good? All right. So let's move on to page 78. This is range of motion, elbow and wrist. Now we learned range of motion earlier today. This is just another range of motion skill. We already know how to do this. We just have to look at the care plan to tell us what body part, what exercises, and how many repetitions. So if you look at the top page 79, you can see the care plan. And it tells us to provide the following range of motion exercise to the resident's right elbow and right wrist, flexion extension. So we're going to use flexion extension on the elbow, which is up down. And we're going to do flexion extension on the wrist, which is up down. We'll do each one 3 times, put an opening in front and a closing behind, and that's the whole skill. So let me get somebody to come over here and lay down in this bed, and I will show you this skill. So as we're go ahead and lay down. As we're doing this, we want to remember to support the joints from below with a flat palm. We're going to move slowly and smoothly, return all the way to the start position, ask about discomfort, and we'll do the opening and the closing as well. We don't need gloves for this because our patient is, holding on to all their own body fluids, unless you see a scratch or an incision or something like that that you would want to wear gloves for the test. We don't have to worry about that. Okay. So I'll show you this one from beginning to end. I will simulate hand washing for the sake of time because we need to get into blood pressure. So remember, after your first skill is done, the evaluators will tell you that you can simulate hand washing. That just means say that you would wash your hands. So I'll be doing that for this skill. Here we go. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you?
I'm good. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay? Okay, I'm going to close your curtain. Let me go wash my hands, get my supplies, and I'll be right back. My hands are clean. I've just washed my hands, however you want to say it. All right, Ms. Jones, I'm going to do all the work. All you're going to do is let me know if there's any pain or discomfort as we do this, okay? So the first thing I'm going to do is just bring your arm straight out, palm up. I'm going to bend your arm up like you're making a muscle and then back down to the bed. We'll do this 3 times. Let me know if there's any pain. So up and all the way back down. Feel okay? Up, all the way back down. That's 2. One more. Up, all the way back down. Still all right? Okay. Now we're going to move on to the wrist. I'm going to make a loose fist. We're going to go forward and back like you're revving a motorcycle. We're going to do this 3 times. Let me know if there's any pain. Forward and back. Feel a little stretch. Okay. Forward and back. Any pain? Forward and back. Good? All right. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here, like a magazine?
Yes.
Okay, let me see what I can find. Here's call light. Put it in your hand. If you need anything, just go ahead and hit that red button. Your environment is clean. That is in the low position. I'm going to open the curtain. Let me go see if I can find you a magazine. I'm going to go wash my hands. Think about the steps of my skill. Make any corrections. My skill is done. That's the whole skill. I would want that skill. Okay, thank you. It is a very comfy bed. Very comfy. Now, one thing about making an occupied bed that I do want to go back over with you, because I really didn't talk about it a whole lot in the video, is that when we put, oh, I forgot this. When we put the pillow back on the bed after we change out the pillowcase, we put the opening of the pillowcase away from the door. A lot of people walking up and down the hallway, lots of pathogens, germs. We don't want those pathogens to come in on air currents and find a nice, dark, moist place to land inside the pillowcase. So opening of the pillowcase faces away from the door. All right, good. Okay, here we go. Let's go to page 56. This is the part you've all been waiting for. First thing that you need to understand is that blood pressure is not tested on the state exam in Florida. We do not have to perform blood pressure. Manual blood pressure is still tested in a few other states, not many. Some states are using automated blood pressure as a tested skill. You put the cuff on, they make sure you put it on right, you press the button and you write down the numbers. But Florida doesn't test anything with blood pressure. That doesn't mean you don't have to learn it. Every healthcare worker needs to know how to take a manual blood pressure, because if a machine gives you an abnormal reading, we have to double check it manually. If you come to me and tell me, hey, that patient's got a blood pressure of 160/92, I'm not going to call the doctor with that information. I need to verify it and make sure that the machine isn't going wonky. Somebody may have dropped the machine and knocked it out of calibration. The batteries on the machine may be going bad and giving a false reading. We don't know. We don't know if it's a machine problem. The only way to find out is to manually check the blood pressure. And that's why CNAs need to know how to manually check a blood pressure. So that's what we're going to go over today. But please remember, it is not on the state exam. Okay? Taking the blood pressure is not on the state exam. Now, knowing normal values is. You will have some written questions on blood pressure, but not skills. Okay? Good? So let's discuss what a blood pressure actually is. So on the left side of your chest, you have a heart. That heart squeezes. It pushes out a wave of blood. That one pushes the one in front of it. That one pushes the one in front of it. Remember this from pulse. So if we have waves and they're defined waves, that means there has to be a valley in between. So the heart contracts and pushes a wave. The heart rests and there's a valley. The heart contracts and pushes out a wave. The heart rests and there's a valley. Good? Questions? Okay. This is what we're measuring when we're measuring blood pressure, is how much pressure is inside the artery when a wave is moving through, and how much pressure is inside the artery in between waves, or when the heart is at rest. Normal values for the top number, 100 to 119. We call that the systolic reading, or squeezing. Systolic is squeezing. And the diastolic, or bottom number, is 60 to 79. These are our normal values. This is what we're looking for. If we get anything outside of this normal, we report it to the nurse. So, heart squeezes, pushes out a wave of blood. That wave pushes the one in front of it. That one pushes the one in front of it. But this is kind of hard to visualize. So let me give you an example that has nothing to do with hearts. Let's say that I'm at my house and I'm outside, I'm going to water my flowers, and I have a hose attached to a faucet or a spigot on the side of the house. Right now, the hose is off, or the faucet's off, so the hose is nice and soft and pliable, just kind of laying there, not doing much of anything. But when I turn that faucet all the way on, the hose expands, gets bigger, stiffens up, right? Now I've got pressure inside, water pressure. So how much water pressure depends on how high I turn the water on. So this is what the heart does. The heart is standing at the faucet going on, off, 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 on, off. Okay? Make sense? So when the faucet is on, the hose has expanded. There's pressure inside. When we turn the faucet off, the hose gets squishier, deflates. There's less pressure inside. When we're taking a blood pressure, we want to know how much pressure is in there when the heart is squeezing and there's blood in our hose, and how much pressure is inside the hose when the heart is not squeezing. systolic, diastolic. Okay, good. So how do we get these numbers? That's the part of blood pressure we have to learn. All right. So we're going to use a gauge to get these numbers. And your blood pressure gauge probably looks something like this. As CNAs, we only inflate to somewhere between 160, 180. That's our stopping point. Do not go above 180. Anybody ever have your blood pressure taken? Yeah, when that thing goes all the way up, what does that feel like? It hurts. Squeezes. You're like, whoa, dude, that hurts. And the further up they go, the more it hurts, right? Anybody know what effect pain has on blood pressure? What does pain make blood pressure do? Yeah, it makes it go up. Absolutely. So if we inflate our cuff beyond 180 and we're hurting the patient and we get a high blood pressure, there's no way of knowing if the patient actually has high blood pressure or if we just gave it to them because we hurt them. So as CNAs, we only go up to somewhere between 160 and 180, and then we start to come down. Good? That's our stopping point. Because if you remember our banner over there, CNAs do normal. So if the patient has super high blood pressure, is that normal? So who is responsible for taking those blood pressures? Very good. Okay, good? Make sense? We already have the system in place for that. So we are going to inflate, between 160 and 180. We're going to inflate to between 160 and 180, and we're slowly going to deflate. So that needle's going to come down slowly, and we're going to listen for two very specific things. The first thump that we hear and the last thump that we hear. That's what we're going to listen for. There's no counting. It's just where is the first thump? Where is the last thump? That's a blood pressure. Where we hear the first thump, wherever that needle is pointing, that is our top number. Wherever we hear the last clear thump, whatever number that needle is pointing to, that is the bottom number of our blood pressure. That's all blood pressure is. We inflate to somewhere between 160 and 180. We deflate and we listen for the first thump and we listen for the last clear thump. Well, that means, though, this is important. When you inflate that cuff, if we're listening for the first one, that means we're not going to hear anything right here. We're going to deflate and listen and listen and listen and listen and listen and listen, and it's quiet and it's quiet and it's quiet. Thump. Good? So when we're taking a blood pressure, we're not going to hear anything right away. That's important for you to understand. Remember, we're listening for the first one. The first one means there's nothing before it. First is first. Does that make sense? Okay. So that's the thing that really messes students up quite a bit is they inflate and they don't hear anything. And they're like, oh my gosh, I'm not doing this right. You're not going to hear anything. It's going to be quiet. Quiet, 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 thump. Where that needle is, that's our top number. Then we're going to hear more thumps. Thump, 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 thump. We don't care about those. We're not counting them. They don't matter. Doesn't matter how many. It doesn't matter how hard. They don't matter. They don't count in our book. We're listening for the last one. But the problem is you won't know it's the last one until nothing comes behind it. It doesn't tell us, get ready, get set, here I come, ta-da. It doesn't do that. It just, you inflate, quiet, 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 thump. Oh, that's my top number. Thump, 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 thump. You won't know that the last one is the last one until there's nothing after it. So we have to pay attention to each one because it could be the last one until another one shows up. Oh, then this one could be the last one. And then another one shows up. Oh, this could be the last one. And then another one shows up and, oh, this could be the last one. And then no more show up. Okay, that was the last one. Okay. You understand how this works? Now, once you hear the last thump, we want to continue listening all the way to 0. Because just because we thought we heard the last one doesn't mean that one more might not show up to the party. Could be a latecomer. We don't know. Okay. We're going to listen all the way. Good? Everybody understand how this works? What do we inflate to? Yeah, 160 to 180, somewhere in there. Don't go over 180. When we're deflating the cuff, what are we listening for? The first one, and that is our top number. We're going to hear more. We don't really care, but any one of them could be the last one. And what is our last one? Bottom number. And we're going to keep listening until we get to 0. That's blood pressure. It's not as hard as people think, but it's not as easy as it sounds either. Because this is going to take hand, eye, ear, and brain coordination. Everything has to work together because our hand is squeezing the bulb and letting the air out. Our eye is watching the needle. Our ears are hearing for the first and the last thump. And our brain has to put all of that together. So although it is simple, it takes practice, a lot of practice, like 45 blood pressures before you even start to get accurate. You will not be accurate today. Do not ask me to double check your readings. You will not be accurate today. You might think you are. You might be close, but it takes some experience here to get all of this together. You're also going to feel like you need one more hand. And unless you plan on growing a third one, we got to learn how to make do with the ones we've got. So this takes a little practice as well. Okay. Does that make sense? Good. All right. So we have 2 pieces of equipment to make this happen. So let's pull out our blood pressure cuffs and stethoscopes. What's that? You didn't bring yours? Okay. Yeah, I was running a little late on Wednesday and forgot to tell you. Okay. You can still kind of follow along. All right, so we have 2 pieces of equipment to make this whole thing work. We have a blood pressure cuff and a stethoscope. This is the blood pressure cuff. This is the stethoscope. We need to learn how to use them both, and they're not as user-friendly as you would think. So we're going to start out with a blood pressure cuff. Your blood pressure cuff looks like this. Has lots of different parts to it. And we're going to go over each part in detail. So if you have a new blood pressure cuff, your gauge is not attached. This gauge is heavy. It has prongs on the back, but we don't just hang it in place because as this is moving around, this could fall off and your patient's wrist is right below it. If this hits the wrist, it could break the bones. So we need this to be firmly attached to our cuff. On the back is a little clip. If you press down on the bottom of the clip, the top magically opens. If you open your clip and slide it up this tab, you have a tab, fabric tab. Slide it up your fabric tab, and now it is securely attached. It can't fall off and hit your patient. So the clip, nope. So the clip, the bottom, press the bottom, and we're going to slide it up. Okay, did you get yours? Okay, did you get yours? Did you get yours on? Okay. Yep. So we're going to press down on the bottom of the clip. Oh, let me put yours together. Hold on. Some assembly required. So we're going to press down on the bottom and slide it up. There you go. You're welcome. All right. So it's very important that your gauge remains firmly attached to your cuff so that it doesn't injure the patient. Now, the bulb and valve assembly here is what is used to put air into and take air out of the cuff. If you don't listen to anything else, you need to listen to this. Do not inflate this cuff unless it's wrapped around something, because the balloon inside has to press against something. If it doesn't press against something, this balloon inside can burst, and then your blood pressure cuff is no good. So this has to be wrapped around something to inflate and deflate. So when you're practicing, don't just start putting air in here, because it can burst your balloon. Okay, good. Questions? All right. So the bulb and valve assembly is how we're going to put air in and take air out. The little dial on your bulb and valve assembly is how we're going to do that. So think of it as a door. Righty-tighty, lefty-loosey. So we're going to turn that little dial to the right if it's facing us. The way to hold this, okay, is you see how the tube is up, not down. This is not correct. The tube is up and this dial is facing me, not out. The dial faces me. I want to hold that dial between my thumb and finger, and this is how I'm going to control it. I'm not going to let it go. This is my long lost love, and I'm not going to let it go. So I'm going to turn it all the way to the right just until it stops. Don't tighten it because we have to loosen it in a minute. So we're going to turn it all the way to the right. Don't pump yet. We haven't wrapped it around anything. We would pump air in, and then I'm going to hold this little bulb and valve assembly and turn it ever so slightly to the left to let air out. When I say ever so slightly, I mean teeny tiny itty bitty motions, like tiny hair. If I do this, woo, that needle's going to go woo, and I'm not going to hear anything. So tiny motions, okay? Good. So when we hold that valve, the bulb and valve, this is in our hand like this, and this dial is facing us. So when we close the dial, we're going to squeeze the bulb to put air into our cuff, and that's going to make the needle go up. As the needle goes up, we're going to stop it when it reaches 160 to 180, somewhere in there. And then we're going to slowly open that dial. And when we do, the air is going to come out of the cuff. So this is a graphic that shows what's happening in the arm as this whole process goes on. Okay. So we put the cuff on and the needle is at 0 starting or near it. We righty-tighty, squeeze our bulb, and that needle goes up to somewhere between 160 to 180. As it does, and air is going into this cuff, that air is going to push in on that artery. Just like that. And we're actually going to close off that artery. That means that hand has no blood flow. We are closing an artery. You leave that artery closed too long, that hand's going to reach up and smack you. We don't want to leave this cuff on for a long time while we're fiddling with it. So we're going to inflate and then we're going to deflate. Don't leave an intact cuff inflated on an arm for a long period. It hurts. And their hand is not getting any blood. So once we get it up to somewhere between 160 and 180, we're going to slowly open it. But let me explain what's happening inside the body when this is happening. So our heart's still beating. Thump, 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 still beating. Each one of those heartbeats is going to push a wave of blood out. So those waves can't get through because we closed off that artery. So they're just kind of like a traffic jam, sitting patiently in line, waiting. But they can't get through because the cuff is closed the artery. Good? Makes sense? As we open that valve and release some of that air, okay, we're going to open the valve and release some of that air so that needle comes down. As that's happening, this cuff is gradually going to release that pressure and open that artery. Eventually, that artery is open enough that the first wave can get through. And as the first wave travels through this cuff, this opening, as that first wave travels through, we're going to be able to hear it with our stethoscope because it's going to hit the top of the artery and make a thunk sound. So let me go back real quick. This is why, this is why when we inflate, we can't hear anything because the waves aren't coming through. As we deflate and the waves start to come through and they come down past our stethoscope, we're going to hear a thunk sound. That first thunk sound is our top number. Wherever the needle is, when we hear that first thunk, is our top number of the blood pressure. Does that make sense? Well, just because one wave was able to make it through, the rest of them are going to be able to come. So you'll hear more waves. Thunk, 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 thunk. We don't care about those. Don't care about those. We're going to hear lots more thunks. So the first wave to pass under our stethoscope where the needle is, that is our top number or systolic. More waves pass. We don't care about those. And then eventually the artery is so opened up that we don't hear any more thunks because they're not hitting the top of that artery anymore, and the thunks stop. The last thunk we hear is our bottom number. Okay. Good? You guys understand this? Sort of, kind of? So last thunk means there's no more sounds after it. That means that the artery is open enough that everything is able to make it through without hitting the top of that artery. That's the bottom number we're looking for. So for this example, our blood pressure was, when we got our first thunk through, right here, this is 118. And our last thunk occurred at 78. So our blood pressure is 118 over 78. If you remember, our normal values were 100 to 119 for the top. 118 is in there. 60 to 79 for the bottom. 78 is in that range. So this is a normal blood pressure. Now we're going to keep deflating until the needle hits 0. Then we can remove our cuff and record our reading. So the number where we hear our first thunk is the top number. So here, this is where we heard the first thunk. That is our top number. And here is where we heard our last thunk. That is the bottom number. So now we need to learn how to read the dial. Okay, good. Questions so far?
What if the pressure is 120?
Okay, so 100 to 119 is normal. If our top number is 120, is that normal? So what do we do with abnormal? Report it to the nurse. Yep. Yep. Good. Makes sense? Okay. So let's learn how to read this dial. So if you look at this dial, you'll notice that everything is marked in 20s, right? We have 0, 20, 40, 60, 80, 100, 120, 140, 160, and so on. The big lines in between are your 10s. So this is 20, that makes that 30. Even though 30 isn't on the dial, that's what that big line represents, 30. 40, 50, 60, 70, 80, 90. Good. Little teeny tiny lines in between are 2s. So if this is the line for 100, this is 102, 104, 106, 108, 110. Okay. So the big lines are 10s. The little lines are 2s. Notice there's absolutely no line here. Let's look at this real quick. This is 140. It's marked. This is 142, 144, 146, 148, and 150. There are no lines for 145. You guys see that? It's all even numbers. There's no lines for 145. We have a line for 140. We have a line for 142, 44, 46, 48, and 50. But there's no line for 145. So if you tell me that you got a blood pressure of 145 over 79, I know you're guessing. There's no line for 145. You're guessing. Don't guess. Make sense? Report even numbers. All right, so to recap, we're going to inflate to 160 to 180. We're going to deflate slowly. We'll listen for the first thunk, which is our top number. We're going to listen for the last clear thunk, which is our bottom number. And then we're going to deflate to 0 and document. That is blood pressure. Now, let's take a look at this screen, and you can tell me what the blood pressure is. So we inflated to 180. We deflated, nothing here. And then we hear our first thunk here. So this is 100. That's 102, 104, 106. So our top number is? We heard more sounds we don't care about. And our last one is here. So this is 70 here. So a tick below 70 is 68, because we're going backwards. A tick below that, what's 2 below that? 66. So 106 over 66 is this blood pressure. So in your book, go to page 57. Now, these thunks actually have a name. They're called Karotkov sounds, but that's a whole lot to say, Karotkov. So we usually call them thunks, but they do have a name. They are called Karotkov sounds. So if you look in the gray box on page 57, let's look at number 8. Can you guys tell me what the blood pressure is using the little graphic to the right of number 8 and 9? What is this patient's blood pressure? I know it's small and it's hard to read, but 130 over 90. That's right, because 90 is between 80 and 100. So 130 over 90. Is that a normal reading? What would we do with that? Okay, so let's look at 10 and 11. So number 10 is asking, what is this blood pressure?
118/62.
Not 118.
60?
62.
I don't know.
Yeah. Yeah, 108 over 62.
Oh yeah, 2.
Yep, twos.
I couldn't see it.
I know, it's hard to see. I know. Do you guys understand why? Count by twos. Good? Good? All right, let's learn about our stethoscope now. This is probably more important than what I just showed you. So when you have a stethoscope, this is a stethoscope. Your stethoscope has a large flat side to it, and it may have a smaller side as well. It doesn't matter whether it does, we don't use this. The large flat side is called a diaphragm. Okay, the large flat side. What you need to know is it's essentially a microphone. We are trying to hear a wave of blood hit the top of an artery buried under muscle, fat, and tissue. This is not a big sound, guys. We need a microphone to pick it up. We're listening to a wave of blood hitting the top of an artery buried in the body. Not a big sound. So we're going to use the large flat diaphragm or microphone to pick it up. Some stethoscopes have two diaphragms. They have the large one and then they have a small one. If it's flat, it's another diaphragm. If it's like mine, a little cup, it's called a bell. Doesn't matter. We don't use it as CNAs. That's for nurses. We are going to use this side. The problem is that this stethoscope has no idea which side I want to use. And it's a microphone. It can't amplify everything because if it did, we'd hear the ceiling fan and the lights and people talking. And we don't want to amplify out here. We only want to amplify what we're listening to in the body. So we have to tell this stethoscope which of these sides we want to listen to. And to do that, we are actually going to turn the head of this stethoscope completely around to tell it which side we want to listen to. Now, some of you have a little dot that you can see. Mine has a dot. Some of yours will just have a flat bar. See how one side's flat and one's curved? The flat is your dot side. And some of yours don't turn at all. Yours does not turn. So I'm going to come around really quickly and help you with this. So yours has a dot, so we want the big diaphragm facing the dot, but the whole thing turns. You want the big diaphragm facing the dot. You see yours? Okay, good. You're on the flat bar. Good. Yours does not turn. So yours, yep, your dot is here. So you want your big diaphragm facing the dot, like this. Okay. So yep, there's your dot. So we want to turn that so that the big diaphragm is facing the dot. And yours does not turn. Okay. All right. Good. That's important to understand because when you shove these things back down in your cases later, the whole thing might flip over. You take it out to practice with it later on tonight. And if it's not facing the right way, you're not going to hear anything. So always check to make sure your large diaphragm is facing the right direction. Now we're going to get to the earpieces. I'm missing a few. Okay, now we're going to get to the earpieces. Oh boy. Okay. All right, I got some work to do here, guys. We'll work on that later. Okay, your large diaphragm has to face the dot. Now let's go on to the earpieces. Remember I said that this is a microphone, right? And we're trying to pick up a wave of blood hitting the top of an artery, very small sound. We need to make sure that these earpieces are directing that sound at our eardrums and your ear canals are not straight. Your ear canals are actually a little bit forward. So you just flip your whole one. Don't turn them. Just flip the whole thing around.
What do you mean?
So,
Nice.
yeah. See how they're facing you right now? Now they're
okay.
facing away.
My bad.
Okay. So the rest of you have to adjust yours. So if you take, if yours are straight like this, right? They're straight. Hold down here at the chin strap and then just turn your earpieces a little bit forward, just a little bit. They should look like this, just a little bit forward. Okay, little bit. Yours are already preset, so we're just going to turn the whole thing around like that. Okay, so when you put these in your ears, they need to face forward, away from you, not like this. They don't go in like this. They go in like this. So I want you to face them away from you and put them in your ears. And then tap on your diaphragm a little bit. Tap. You should hear it clearly. You hear it? Take them out. Flip them around. Put them in. And then tap on your diaphragm again. Can't hear much, can you? Now take them out. Flip them around. Put them back in. Okay. If you can't hear the blood pressure, it is most likely because you have your earpieces in wrong. Okay. Now, we're trying to listen to, this is a microphone, but it can only do what it can do. We're trying to listen to a wave of blood hitting the top of an artery buried deep in the body. If I have a microphone on, you can hear me just fine. If I have the microphone in the wrong spot, you're not going to be able to hear me as well. So that means that we need our microphone in the right place to be effective. Our microphone needs to be over the artery to be effective. So that means we need to know where that artery is. So if you hold your arm out, straight out, pop that elbow up so that your arm is straight and flat. 2 fingers, never use your thumb to find a pulse. 2 fingers at the fold of the elbow on the pinky side. So on the inside, thumb on the back, not in the middle. Pinky side, thumb on the back. You should be able to feel your thumps. That is where the stethoscope goes. It's not in the middle. It's on the pinky side. So if we put our stethoscope here in the middle, we are not in the right place. We're not going to hear all the thumps. Good? You guys get that? Now, keep your fingers there. Once you find your artery, keep your fingers there and let your elbow relax a little bit. What happened to your thumps? They went away. So if your patient's arm is bent, you're not going to find the thumps. What position do their arms need to be in? Straight. Get that arm straight to feel the thumps. Make sense? So the way that we do this is we take a blood pressure cuff. Just don't do it with me. Just watch right now, okay? We take a blood pressure cuff. We lay it on the upper arm, and we want it above the fold of the elbow, not down here. Remember, if I've got a microphone, you can hear me. If I cover that microphone up, what happens? It muffles it or deadens the sound. So we don't want our stethoscope or our microphone underneath the cuff because it covers it and it deadens the sound. We want this up. Good? So we lay this here. We find our thumps. We line up our arrow with where we felt the thumps. This is our X marks the spot. And then we secure our cuff. Now we know exactly where to put our stethoscope because our arrow tells us. This is where you found the artery, right here. We put our stethoscope in our ears with the ear tips facing forward. Put the diaphragm on the skin and sandwich it in, scrunch it in place. You got to hold it stiff because we don't want air to get underneath with sound. We inflate up to 180. We deflate slowly to 0. We listen for the first thump and the last thump. And then we take the cuff off. And that's a blood pressure. So you guys have got 10 minutes. I want you to break up into groups of 2 and practice on each other. I'll have one group of 3. So you 3 will work together. Okay. So you'll take hers and then let her borrow your equipment, and you'll take her, just take each other's. Okay. So you've got 10 minutes. Go ahead and practice blood pressure on each other. All right, those of you at home, thank you very much for joining us. We will see you again on Wednesday. I'm going to go ahead and shut off the camera for today while they're practicing. Remember, the review sheet is on our courses website under Lesson 1. You can catch a review sheet for today. Thank you for joining us. Catch us tomorrow. Is it tomorrow? Yeah, tomorrow for our game show. Game show has practice test questions. You can win prizes. So tomorrow at 11 will be the game show. So tune in for that. Till next time, happy caregiving. Bye.